Good afternoon. Good afternoon. Good to see everyone. If you would, please take your seats. We're a little bit late getting started, but not as late as the clock in the picture. So, do want to welcome everyone to our Thomasville Bainbridge meeting, and glad that you all were able to be with us. And we've got a pretty aggressive agenda for the next 2 days. Of course, today here in Thomasville and tomorrow over in Bainbridge. So we've got a lot of ground to cover, and just as we've done in the previous 2 meetings. So thank you all for being here, and as we begin a conversation dealing with health care and behavioral health care, I think you're going to learn an awful lot, and probably going to come away from here scratching your head about, okay, so now we learned about it, what we're going to do. So that's kind of part of the process, is educating us and understanding the issues to begin with, and then going forward from here and trying to find solutions. So thank you all for being here, and I'm going to ask my co-chairman, who is sitting behind me, to come forward and introduce some of our local folks that are here to bring some greetings. Chairman Powell.
Welcome. We're excited to be here in Thomasville and excited to be in southwest Georgia. As many of you know who have been following some of the activities of this group, we have a mammoth task ahead of us, but we have been receiving a lot of favorable feedback from the 2 meetings that we've had previously, and have been encouraged by the fact that people understand that what we are trying to do is to almost do a holistic approach for the rural issues that face rural Georgia, and would ask all of the presenters, because we all know that we've got problems, but we want to address the challenges. We want to find out what the problems are, how they are specifically unique in rural Georgia, some suggestions for how to possibly fix them or address them, what kind of money it may cost. But healthcare is probably one of the biggest issues that we're going to tackle, probably because there is a limit to what we can do at the state level, just because so much of this is subject to what the feds do. But we are still hopeful that we can make a significant impact on healthcare in rural Georgia, and that's one reason why we have scheduled 2 different sessions, one here and one I think in Metter. This is primarily dealing with developmental disabilities, mental illness issues, but others healthcare issues as well. But the rural hospital situation and those kinds of things we will be dealing with primarily in Metter, even though they're probably going to bleed over. We've got a group from some of our local governments, I think, who are here, and they may not all be here, but I'm going to call out the names, and if they would come forward. Mayor Greg Hobbs, County Commissioner Zippy Vanier, and Shelley Zorn with Economic Development. So if y'all would come, and we're glad that y'all have agreed to host this in your community. Thank you very much.
I want to say, first of all, very thankful for y'all being here. On behalf of Thomas County and Commissioners, we'd like to welcome you, legislation, and the local guests to Thomasville today. We are thankful for the interest of our legislature in the healthcare needs of this area. We especially have concerns about mental health issues in this community since the closing of Southwest State Hospital. We are looking forward to future healthcare plans for our community, and we just enjoy having y'all seeking our input for this healthcare. We thank y'all.
Well, good afternoon and welcome to Thomasville, Thomas County. I'm Shelley Zorn. I'm the economic developer here. And Darlene Taylor told me yesterday she wanted me to give you a little overview of Thomasville, Thomas County. So that's hard for me to do in 10 minutes, but I'm going to stick to it. How many of you, of course, are from here or live in southwest Georgia? Okay. And how many of you been to Thomasville before? Okay, so I don't have to give you too much background information, but our city manager is here, Steve Sykes, and he's heard this stump speech a lot. So he's the only one that can't answer on this slide. This is a participation here. Thomasville, Thomas County really truly has been progressive from the start in every area. I know your focus today is healthcare, and we've been progressive in that area, but rural broadband in every area. But this slide from the 1800s is a really good depiction of why we have been progressive from the start. So does anybody know what it is about this slide, this picture? This is our downtown in the late 1800s. I know it looks like every other downtown in rural Georgia at the time, a dirt road. What would you tell me that would give you a sign that? Electricity, very good. We've got some power people in the building. So City of Thomasville, because of our past and our history and the plantation life here, we have 71 private hunting plantations. And when they came here in the 1800s, that was an economic boost then, and it is today. So because of that, we got to sell our own electricity. That was just one example of how we're progressive from the start, and that electricity and the revenue from that electricity still gives us resources today that I think other rural communities don't have, and we're very appreciative of. The other thing that I think sets Thomasville apart is we're a regional leader, and we have economic diversity. So the economic diversity starts with our hunting plantations, big economic impact here, over $67 million a year from those visitors coming to our plantations. The other thing that sets us apart, when I first moved here, everybody would say, well, how do you like Thomasville? And I'd say, well, it smells like bread because the flour's baking, and the downtown is gorgeous. So the downtown is a tourist draw, and because of some of those resources that we have from plantation, from selling electricity, from selling other services, we have invested it in our downtown, and people come because of that. So over $83 million has been spent in our downtown in the last 20 years. That brings tourists every day, it creates jobs every day, and it gives us diversity as well. City of Thomasville in particular has really set itself apart, and what I really like being somewhat new to Thomasville now, I've lived in a lot of different places, is that they never just rest on their current success. They're always looking for something else. So they recently created an amphitheater, which creates tourism downtown. They're working on bike trails and walking trails, which will bring people to town and boost the economy, and some other ideas. Small business services in particular are very important here. We're looking at some new ideas as far as incubators, or what we might call that. It may end up being something different than an incubator, but very important to us. Economic diversity, again, I don't think you'll find another rural community that loves the arts and does arts programming like Thomas County. So we have an arts director here that believes art creates economic development, art creates jobs. We all partner together to make sure we keep that diversity. Healthcare. Our hospital here is our largest employer. I know that's what you're going to focus on today. 2,500 people are employed here in Thomasville and in this region because of our hospital. So when I have an industrial prospect in town, I love to take them by the hospital. Not only do they always have questions about that, and that's very important to them, our health care here in this region, but our hospital, how many of you have seen our hospital? It looks like a beach resort instead of a hospital. Not that anybody wants to go to the hospital, but if you have to go, and I've been, it's a great place. Education, we're a regional hub for education with Thomas University and with the technical college that you're at today. People really do come here for jobs, for retail, for shopping, for healthcare, for education. We have a 7-county draw here, and so our population is about 44,000. But if you look, we visit our existing industries constantly, and if you talk to them, you'll see about half their job numbers, half their workforce are from our surrounding counties. Existing industry is extremely important here. It's another spoke in the wheel. You got to have education, you got to have health care, but you have to have existing industry. So we have about 100 existing industries here, everything from Flowers Corporate, Flowers Bakery, to that 5-person machine shop. And I think this is unique in rural Georgia as well. We have made a commitment, my Development Authority Board has, that any existing industry will get the same incentives that a new industry. If you're creating jobs and you're an existing industry, we'll give you the same incentives, and that's on our website. So we've created over 650 jobs in the last 2 or 3 years just from our existing industry. And of course, we'd love to get those announcements of new industry, and we're working on that as well, but we really think this is our backbone. We have 5 corporate offices here, also very unique for a community our size. Last but not least, we always try to recruit new industry, and I know you're talking about that topic on another day. Now you'll discuss it constantly, but we've invested. This is a great county and city project in a new industrial park here. We've also recently invested to purchase the former Caterpillar building. So it was a huge investment for our community, but again, progressive from the start, and they see the need to stay progressive. So I would just thank you for being here today. I appreciate this group and what you're doing. I think it's very important to discuss these topics. Now, of course, I'm the economic developer, so I'm going to give you the stump speech, and I'm going to give you all the good. And of course, there is a lot of good, but I appreciate that you're addressing some of the challenges. As great as Thomas County is, we definitely do have challenges. And economic development is very, very hard in Southwest Georgia and all of rural Georgia. So we very much appreciate you addressing it. We really do. If there's anything we can do, if there's anything I can do, I'd love to help this group. I think it's very important what you're doing. The last thing I'll say is I've lived in a lot of different size communities, and Thomasville is what I would call a medium rural community. We have some resources that some of the other communities, some of our neighbors don't have, a lot of people in Southwest Georgia or North Georgia don't have. So I know you're keeping that in mind. I know that that's why you're here today, to think about the rural communities of every size. We all face challenges, but those towns of 5,000 or 10,000 face even bigger challenges than maybe Moultrie or Tifton or Thomasville. But we appreciate you being here today, and we appreciate your help, and I'm very anxious and very excited to see what you're going to talk about today. Welcome.
Again, thank y'all for your hospitality, and it's always good to be in Southwest Georgia, deep Southwest Georgia. For one of us Northeast Georgia boys, it's good to come down here, and would say I saw some of the prettiest cotton on the way down here that I've seen in probably 25 years. So I'm tickled to see the condition of a lot of the crops. Peanuts already covering the middle, so that's a good sign too. So we just hope that prices hold up as we go into the fall. So, as Jay had mentioned as we started off, we're going to talk pretty in-depth about behavioral health and developmental disabilities on this part of the visit here. And as many of you are aware, and those of you from Thomasville are certainly aware, that as we were handed down a verdict or ruling from the Department of Justice as part of a consent agreement, meant that we had to close most of our state hospitals serving those with developmental and mental health disabilities. And so it has put us as a state in a pretty tight spot in trying to figure out how to move these individuals into communities, because that settlement said that these folks had to be moved out of a hospital type setting into a community-based setting, and it has been extremely difficult for the state. It's been extremely difficult for the individuals themselves, and probably more so difficult for you in your areas where you're having to deal with these individuals coming in and trying to figure out how to provide these services. So as we've started down this path, we kind of got our house right with the department and brought in a fellow that had been a part of a community service board, Frank Berry, to be the commissioner of DBHDD, and did such a good job, the governor decided he wanted to send him to do something else. And bless his heart, he got put at Department of Community Health. He will now be an inpatient for some mental health services here before too long, I'm sure. But as the governor was getting ready to make that transition, I kind of panicked a little bit because Frank had done an outstanding job at DBHDD. The providers were happy, patients seemed happy, everybody seemed happy. And so I started panicking a little bit about who they were going to tap to take his place. And those anxious moments went away pretty quickly when I was told that Miss Judy Fitzgerald was going to be the one taking Frank's place there, because I have a lot of faith in her. She had been Frank's chief of staff and been with him through many of the toils and trials that they had went through as they got to the department. And Judy has done an outstanding job so far. She's been on the job about a year, I guess, give or take a little bit. Was named to that post in 2016. She does hold a master's degree from University of Georgia in social work and has a heart of service for people. And that's one of the things that if you ever have a chance to talk to her for just a half a second one-on-one, you'll figure out real quick that she does have a heart for service to people. And that's extremely important in the role that she serves today as the Commissioner of the Department of Public Health and Developmental Disabilities, or Behavioral Health and Developmental Disabilities. So, Ms. Judy, our Commissioner, the microphone is yours, and we're glad to have you with us. Thank you.
Thank you very much. Thank you so much, Mr. Chairman, Chairman Powell, Vice Chair Watson, all the members of the Rural Council. It's a privilege to be here. I know some of you, we've had an opportunity to meet, and in some cases, under challenging circumstances. I want to say as I come here today, and I want to also say thank you for the warm hospitality from the people of Thomasville. I was chauffeured in, of course, by one of my executive team members, Dave Sofrin, who's the former director of Southwest State Hospital, and now sits with us on the executive team in Atlanta. The good thing is, probably not a day goes by without me hearing about, well, that all sounds good, but let me tell you how it looks from Thomasville. So this is very much on our minds about the needs of rural Georgians. And the commitment I'll make to you is, this won't be the only time you'll see me. The needs of rural Georgians, we're going to have to keep talking about, because we're going to talk about complex challenges today, and we're not going to shy away from them. And so I look forward to doing that, but just know it'll be my commitment to keep returning and keep answering questions as best I can, so that we can come to solutions together. So I will look forward to that. I do have a PowerPoint. If we could, so I've got a fair amount of information to share, and I will, because y'all asked me to answer some specific questions. I'm going to do my best to do that. I'm really pleased to tell you I also, I brought a bunch of team members with me. Those of you that work for DBHDD or our contract or partner agencies, would you raise your hands? All right, see, this is good. Y'all are going to ask me hard questions, and some of them I'm going to know, but some of them I'm going to, oh, thank you so much, rely on my team members to help out. So I am going to share some information. I'm going to start out really, as I said, trying to answer some of the questions that you asked before I came down. But to your benefit, I think y'all, well, let me say this first. Y'all were very generous in putting DBHDD first on the agenda. I've been a social worker in Georgia for 25 years, and if you told me that a group of legislators would ever put DBHDD on the agenda first, really for a long time I would have been shocked. But here we are. This is a really pressing need for the state of Georgia. Now the good news for y'all is I have a 13-year-old daughter. She reminds me every day, nobody wants to hear me talk for an hour. So my plan is not to talk at you. I really, as challenging as it may be, I want to give you a chance to ask some questions, but I do want to try first to address some of the things that you asked me to address in coming here. And this should be familiar to a lot of you who've seen our vision and mission. This is good, right? This is real. We do have a vision about what's possible in the state of Georgia, but one thing I want you to be clear about. We don't just have a mission, we're on a mission. And I know that there are many people in this room for whom this mission is not just professional, it's personal. The same is true for me. I'm one of 6 kids, and in my immediate family, we have mental health, addictive disease, and an individual with an intellectual and developmental disability. So what we're talking about is real to me, as real as it is to you in your communities, and that doesn't make it any easier, but I do want you to know my commitment lasts beyond just what we're going to talk about today. This is really, really critical work that we're going to do. I'm also, I want to do my best today to not get caught up in jargon and to be really specific. In healthcare, and certainly in behavioral health and developmental disabilities, we have a lot of lingo and a lot of acronyms, and whether we like it or not, the 3 disability areas that we serve at DBHDD, mental health, mental illness, addictive disease, and intellectual and developmental disabilities, are all different systems. The programs, the way they're funded at the federal level, and the work that we do, the staff that does them, it's a very diverse, as much as it seems the same sometimes to people in the community. A challenging person is a challenging person. There's a lot of variety and variability within the people that we serve. As best I can today, I'm going to try, thank you, and be as clear as I can and be as simple as I can. And if a way I'm talking about it doesn't resonate for y'all, I hope you'll stop me, because I really do want to talk about it in a way that connects with what you're experiencing at the ground level, at the local level, and what we experience as we're trying to solve system-level problems for the state. Okay. So I'm going to start by using a word. Again, this is a word that we use, but I hope it will maybe come to have meaning for you all, which is that all the services that we provide really should be and are a continuum of services. And always the goal, I think this is true in all of healthcare, is we're trying to get folks to the right level of care in the right place at the right time. That's healthcare at its best, right? So a full continuum of services is needed in order to make that happen. So we talk about a continuum, and I'm going to talk about a continuum that goes all the way from the deepest end of the system, hospitals and other institutional care, right, to the most integrated and community-based level of care. That's how we talk about it. Now, when I talk about that continuum, it is not full and whole and complete everywhere we need it to be. And so that's part of the challenge you all are going to raise today, and we'll absolutely talk about that. But I am going to use that word continuum and tell you a little bit about our continuum of care. The chairman has already previewed a little bit how we got to where we are in terms of the closure of Southwest State Hospital. So as the chairman recognized, and I really appreciate that as a starting point, which is that in 2009, the average daily census at the state hospital for the 2 separate disability areas, in adult mental health, it was 56, and for folks with intellectual and developmental disabilities, it was 126. I use that 2009 figure because that was when the negotiations with the Department of Justice were first underway. The settlement agreement was signed in 2010, and just as Chairman England very articulately laid out for us, what that called for, that agreement signed by Governor Perdue on behalf of the state of Georgia and our department, was all individuals with intellectual and developmental disabilities had to be moved to the most integrated setting that they could be served in. And the belief is that all those individuals with the right services and supports can thrive in the community. So that was the agreement we signed. Now, the agreement doesn't say that for individuals with mental illness, okay? We anticipate in the state of Georgia there will always be a need for hospital beds for individuals with mental health needs. What we're moving towards is that in the hospital, those beds will be for individuals with chronic needs that cannot be served in the community, and they'll also be for individuals, forensic individuals, again, another term we use, but for our purposes, that's folks involved with the court system, who've been charged with a crime. They might be not guilty by reason of insanity, or we might be trying to restore them to competency. We will always have hospital beds to serve that population in the state of Georgia. But for the individuals with intellectual and developmental disabilities, the work of the settlement agreement is to provide a life in the community for those complex and sometimes very fragile individuals. This phrase that I put on here, service drivers and fiscal realities. So one of the things, and I want to be as plain as I can in talking about this, it's because it's what we signed on for. Once it was clear that the individuals with intellectual and developmental disabilities would no longer be served in the hospital, the funding that supported those individuals to be served in the hospital, once that's removed, the hospital can no longer afford to serve that small of a population. That's just the fiscal reality that we mean. So very difficult decisions have had to be made about moving services into the community. I'm going to say a lot more about that. I really want to spend more time today talking about behavioral health and about what now it looks like with a continuum in the community. But I want to talk for a minute about those very vulnerable individuals with intellectual and developmental disabilities. And if folks want to know more about that, our work around this has really been transformative. In order for people who have a certain level of intellectual and developmental disabilities, that they were living their life in the hospital, for them to have a life in the community, for us to build a home and partner with a provider so that they could have a successful integrated life in the community, took just a transformation of our system to build community services where people can thrive. And we really, through some of the ways you're seeing here, how we did that was in many cases by working very closely with the individuals' families and their guardians and people who wanted to see what that best life looked like, agreed and participated in the planning and development of really a group home setting. And what y'all know in the agreement, the way that it was fashioned, the group homes had to be 4 individuals or less. This has really posed some financial challenges, but we've overcome that in partnership with our provider community. And it's allowed us to really build, Georgia is becoming a model for individuals with disabilities, really serious disabilities living in the community. So we've been successful. And let me be clear, when we talk about a life in the community, here's what we're talking about. That individuals, to the degree they can have independence, they can participate in a meaningful and fulfilling life, they may need assistance with that, they can have new experiences and become members of the community, make friends. Sometimes they're friends with the individuals in their home or in their community, and in many cases gives them a better opportunity to reconnect with family. But I will say this, and many of you may recall, there was a period of time after doing a number of those transitions into the community that we faced some challenges. We realized that the medical, in particular, the medical and behavioral complexity of some of these individuals who've lived their lives in a hospital, we might have set up a beautiful group home, partnered really well with a provider who was ready to receive that person. But when that individual came into the home, if they ran into medical challenges, in many cases, we had not prepared local doctors and local hospitals really to serve these individuals appropriately. We paused transitions for a period of time and redid our entire transition process so that now I come before you today and I feel very confident in our team's ability to prepare an individual, a provider, and the local community to serve highly complex and fragile individuals in the community. We had to stand up a whole office of transitions and really have a more robust process. And we also stood up an office of health and wellness so that we now have nurses who work for the state in each of the regional offices that really now are directed to keep a much closer eye on the health and well-being of individuals in the community. All of this is what we have to do, really, in order to ensure that people have what they need. We also have an additional service. We implemented intensive support coordination. And every individual with intellectual and developmental disabilities who transitions to the community has an advocate. And this is really, really important. And what we needed to do was have advocates who were better trained to serve behaviorally and medically complex individuals, and really have a better connection to the local community to make sure individuals' needs could be met. Because those individuals who have transitioned to the community cannot come back into our state hospitals. That's written into the settlement agreement. We've also worked hand in hand with our providers in order to make sure that providers have what they need. We have a number of pilots and training projects going on so that we have a much more robust system to serve these individuals in the community. So I could and would be happy to come back and talk more about those individuals as we move forward and as we still continue. We have, as of today, there are 209 individuals that still remain in the hospital with intellectual and developmental disabilities. We signed an extension agreement of the agreement with the Department of Justice, which calls for us to continue moving individuals at a reasonable pace. We do not have a numerical target, but we do have a whole team of people and a transition list right now, active list of 60 people that are in some level of processing towards that transition, and our team will work as expeditiously and comprehensively as we can. I will say this, though. It's important that y'all know this. The Department of Justice comes in on a regular basis. I sit across the table. I commit that we will move, our team will continue to move at a reasonable pace, but we will not move faster than the community and the services are prepared for. So we will continue to press and move and meet the targets in the agreement, but above all, the safety and well-being of the people we serve is the most important thing. So I'll pause there, and then, as I said, let me transition, because I do know more of the questions I think that y'all wanted to ask were about mental health and addictive disease. And when we use those two words together, that's behavioral health. That's what behavioral health is. And I want to talk about the continuum in behavioral health. So it is in some ways separate from the continuum for intellectual and developmental disabilities, even though some providers may serve both populations. Certainly, our community service boards, our safety net in the state of Georgia, our expectation is that they're serving, all our comprehensive providers must serve all individuals, all safety net individuals, whether it be mental health, addictive disease, or developmental disabilities. But now I'll shift and just talk a little bit about the mental health, the behavioral health continuum of care. Because here's the good part. When we signed the agreement with the Department of Justice, the governor and the General Assembly made an unprecedented commitment to partner with us in really addressing these issues at the community level, because you simply cannot close hospitals and just say, figure it out. Our continuum was way too sparse in order to serve those same individuals in the community. So upon the decision for the closure of the hospital, we did something different in this region, frankly, than we did when we closed Rome Hospital. And it's really made a difference. And I know we're all going to talk about some of the challenges, but I have to tell you how important it was that the members of the General Assembly and the governor said, we are going to support financially the implementation of critical services that actually will make community continuum work. So most specifically for this region, you see, and I'll talk about some of the services very specifically because they're critical to your continuum of care and for our ability to meet the needs throughout this region. But what the settlement agreement, when the members of the General Assembly agreed to fund some of the services, the right work to do was fund evidence-based services, things that are demonstrated to work. And I'm so proud of Georgia, and anywhere I go, there are states that look at us and say, wow, you were able to bring all of that in through the generosity of the General Assembly and that commitment to if we have to do this, we're going to do it right. We're going to bring evidence-based services that really meet the highest level of need. And we brought community-based services across the state, but really specifically I want to talk about behavioral health crisis centers in Albany, Thomasville, and Valdosta. And you see the funding there, nearly $18 million new dollars invested in what we call Region 4, that's this area, to expand infrastructure and community-based services. Let me tell you exactly, give you a little what this looks like. We call it a BHCC, Behavioral Health Crisis Center, but I really want you to practically understand what that means, because when you close the hospital door, what you still need is 24/7 care that is available immediately, and that's what these behavioral health crisis centers are. Open 24/7, they're short-term facilities. We need walk-in crisis intervention. They need to be able to receive, they need to be an emergency receiving capability, have a front door that can let people in, and then when it's assessed that that individual has a need right there in that facility, they actually can go into sort of another part of the facility, which is a crisis stabilization bed. So in that context of the crisis stabilization, there's assessment, there's counseling services, and then the idea is that they get stabilized so that they can be connected to the community care that they need. This is not intended to be a long-term service, but it is intended to de-escalate the crisis, understand, and really, whenever possible, prevent an inpatient hospitalization somewhere else in the state. We really wanted to open up care and serve individuals as close to home as possible. So I'll walk through each of these, okay? And they're each going to look pretty similar, but I do want you to know the resource that came into this region by virtue of closing the state hospital. So first, here in Thomasville, y'all are probably familiar that the Georgia Pines Community Service Board is the provider of the Behavioral Health Crisis Center. Wherever possible, we want our safety net providers to be the provider of the crisis center. And that makes sense, right? Because the expectation is those folks are going to have ongoing needs. The sooner we get them connected to their safety net provider in the community, the better, the sooner they'll get to what they need. So it's an emergency receiving facility, so law enforcement can bring folks directly there. It has 24 beds and then 6 temporary observation beds. So that's our terminology, but it isn't, it's kind of what it sounds like it is. Sometimes people in crisis don't actually need to go to a higher level of care. After the crisis is de-escalated, they might be able to go and have a connection to their community provider without taking up precious resources of a crisis stabilization bed. That's what temporary observation allows us to do over a 23-hour period. If you need to go into crisis stabilization, we want to get you in there as quickly as you can. But if you don't, and after a 12-hour period, some rest, some medication, you may be able to move to the community. We want to be able to make that happen. So that's why these behavioral health crisis centers are really more robust and comprehensive than things we had before, because they allow us to make that point of discernment and then connect people. So remember in the beginning I said right level of care in the right place at the right time. That is what we'll continue to do. And so the average annual investment there is more than $5 million, and there were some startup costs to build the center in the beginning. Another one of the behavioral health crisis centers, Albany, that's run by our CSB partner in Albany, Aspire, Behavioral Health and Developmental Disabilities. Again, this should sound familiar. This is what the model looks like. It's an emergency receiving facility for law enforcement. This one has 30 beds with 6 temporary observation beds. So same idea, you come in, you have an assessment, we determine, do you need higher level of care? You may need further crisis stabilization, or we may be able to release you with an appointment back with a provider in the community. Again, the average annual investment there, more than $5 million. Also in Valdosta, the behavioral health, once again, Behavioral Health Crisis Center. This one's run by Behavioral Health Services of South Georgia, another one of our community service boards. Again, you see what the model looks like. It's an emergency receiving facility. We want our law enforcement to have a place where they can bring folks and drop them off, and that is what this provides. So it's 24 beds in Valdosta, once again with 6 temporary observation beds. And again, the average annual investment there, more than $5 million. So I do want to draw a distinction then about adult mental health beds in Region 4, and that's really covers those 3 areas. At the time of the hospital closure, 67 beds for adult mental health in 2013. Now, we have 96 crisis beds at 3 behavioral health crisis centers, and we also have access to beds with some private hospitals that we have contracts with. So it feels different when a hospital closes, but I do want to assure you that the dollars that you put into the building of these behavioral health crisis centers really does open up access and keep it closer to home in a way that many other states would like to have a resource like this. Now, we're going to talk about what else we need, but I do want you to be clear that the dollars you allocated really have begun to make a difference about access in the local community. Do you have a question?
Yes, ma'am.
Yeah.
How often, like in the last year, have any of these facilities had to turn people away? In other words, how often do they get maxed out?
So I'm going to look to one of my team members. Let me answer that in one way. My expectation is that they'll be as full as they can all the time. We want them serving people in the community. But Jennifer, I don't know if you would actually have a data point about how often is that?
Stand up. Chairs are really interesting. I'm Jennifer Dunn. I'm the Behavioral Health Regional Services Administrator for the 24 counties down here. And they're full every day at 100%. We have a spire in the room. They're more than full. We have people in the lobby. Yesterday at Georgia Pines here in Thomasville, we had 3 people in the lobby. So they receive and evaluate everyone. Then they get them to the next level of care. So they're not turning them away as more as redirecting them to one of those state contracted beds that I think Commissioner Fitzgerald is about to talk about. If they have insurance, we try to help get them to somewhere that would take their insurance.
Yeah, so, thank you, Jennifer. And I know Jennifer is familiar to many of you. She is on speed dial with many of the members of the law enforcement, and our hope is that Jennifer is a problem solver, and our field office staff are helping out at the local community. But Jennifer raises the critical point, right, which is if they're all full, what other options are available? Is there another question?
Yes, thank you. That's several things that I had questions about relating, because I hear from my constituents that they are full. Mm-hmm. Does it need to be expanded? Is that something we need to look at? And something just on another side, do we bill private pay insurance? Can the state do that? Because that may be a resource to help fund additional beds if we can have folks doing that. And how many of these are related to drug, and how many are other types of issues and problems? And then I guess you'll eventually get to it, youth and teenagers. There's a lacking of services for them in our region. But
Yeah.
if you could go ahead and address, can we do something to fund it? Are there more beds needed? What does it take to cross that threshold so
Yeah.
that we will accomplish it?
Yeah, so that's, do you have a week to stay? Representative Taylor, you've asked all the right questions. I mean, let me just say that I've agreed, let's talk about these things. And the challenges here, that they're different, but we've got challenges all around the state. But certainly, so when, I think it's reasonable to ask the question, do we need more beds, okay? I think, but you already heard what Jennifer and what all of us want to say is, how do we get the people to the right level of care? And maybe it's a bed, but maybe, and I'm putting this up here because I do want you to see the full continuum of resources that are available in Region 4, and again, supported by the members of the General Assembly in service of, in order to fulfill the DOJ settlement agreement, we had to build actual evidence-based services. The impact that these are having on people in the community is tremendous. So you already heard about behavioral health crisis centers, but that first one, I'll add the assertive community treatment. That's a service for the highest level of need of individuals in the community. So sometimes what folks need is a connection to a community-based resource, all of which these ones that you see before you are. But even with that, right, the question still remains, is there enough capacity in the state? I guess I want to say one other thing about it, too. Every year, as our budget partners know, we ask for new BHCCs around the state. We really believe that this is a critical element of our continuum. And every year, we will ask for as many as we can. And behind the scenes, our team is always doing data analysis of where the needs are throughout the state, so that if we get another behavioral health crisis center, we already know where we'd like to build it and perhaps who we would partner with. But the other thing that we believe is a critical element of our continuum of care is having more robust and accessible preventive services of outpatient and clinical and supported employment and housing and other services that help keep people out of the deep end, right? If you build it, they will come, and if all we do is build a crisis system, that means people enter our system at the point of crisis and then sometimes get stuck there. So part of the other thing that we'll advocate for, as we have for the last couple of years, is really more money to expand access for care earlier at the point of need, that we can serve folks more effectively in community-based services. You asked about addictive disease. I don't know if any of my partners in the room want to give a specific number around the percentage of folks that are touching the BHCCs where there's an addictive disease. Jennifer, I don't know if...
We do track that.
Yeah.
And it's about a 70-30 mix, 70 being the behavior, 70 being more mental health and 30 with the addictive disease. We have seen a slight increase in the addictive disease individuals that are needing services, and so like the commissioner's talking about, we have all these other activities, services, programs that we try to get people into prior to them going into crisis.
So I want to say some more, and I've got a fair amount of information about the opioid crisis and the current response to that to share with you. But I guess I want to say a few other things about the addictive disease services, because the need is great. And, you know, as I said, I'll commit to keep coming back and speaking with you all. You'll ask me hard questions, as long as it's okay with you that then in return, I'm going to tell the truth. And the truth is, the service system to meet the needs for addictive disease throughout the country are very under-resourced. In this state, under-resourced, and in rural areas, very, very challenged. Now, here's the thing, and I want us to be talking about this together as we go forward, because we do need more resources for addictive disease and the growing opioid epidemic, but others as well, other addictive disease needs. The challenge is when we sort of pulled back on the budget for the addictive disease service system a decade ago, you know, in a time of crisis, these are things sometimes that we cut. And it's really hard to build back up the workforce to do those services. So part of what we have to do is not just services, but also really continue to build the infrastructure so that as funds become available, either federally or at the state level, we need licensed, clinical, and certified folks that can actually deliver those services. And we're chasing that right now. That'll be another challenge that we have. If you ask me what's one of the biggest challenges our department faces, certainly in rural areas, but it's across the board, the workforce to deliver the kind of services we all want. We don't want people in jails. We don't want them in the back of the sheriff's car. We want clinically trained and licensed folks delivering the care, but there is a dearth of those folks everywhere, and you guys feel it tenfold here. So that answer?
Yes, thank you.
Okay, and we'll talk more about opioids in a bit. I did want to say a word again, because I do know for many of you in the room, what you're faced with is the urgent crisis. You hear me talking about a continuum of care, that all sounds well and good, but I know for many of us, what we want to know is, what do we do in a moment of crisis? And we do another service that was funded by the General Assembly through the settlement agreement with the Department of Justice was our mobile crisis response teams. And by virtue of the settlement agreement, we're required to have mobile crisis available in every county in the state. And that is also what you imagine it is. It's 24/7 community crisis response where individuals delivered by professionals can come on site. They assess the need for someone to actually come on site, de-escalate a crisis, work with a family or perhaps other professionals involved, and get the person to the right level of care in the right place at the right time. That is that's their challenge. So it is available currently in all 159 counties. I was asked about whether or not the mobile crisis teams are meeting their targets for response times. What's built in is that into their contracts for the mobile crisis contractors is that the average response time for the state has to be 1 hour or less. I think on my next slide, you'll see where we are. We're at 59 minutes as average response time for the state. So what you know that means, if I tell you that's the average response time for the state, is that in some cases that's over an hour. And once again, y'all in the rural areas are feeling that challenge more than other places where just the geography is different.
Are these state employees, or are they private that we contract with?
They're 2 private companies that are divided among the regions.
Thank you.
Now, we do manage these contracts, and I would say, again, here's the good and bad thing in my own experience about having the Department of Justice at our door regularly. Well, the good thing is like really limited and getting smaller, I feel like, every week. But what it does, it forces a level of accountability. We have to report on these numbers and our oversight of all the contractors on a regular basis. And it really does help build a different level of accountability into our system. So if you tell me, and I think later this afternoon I won't be here, but I know you'll hear stories about times when it was more than an hour. That is true. I wouldn't defend that, but know that where providers are not able to meet the targets that they've set out, they do have to come forward with corrective action plans and make adjustments in order to get closer to the targets. And for the most part, they've been able to adjust appropriately as we have so much more information available to us now, and it really is strengthening our system. Our mobile crisis partners, it really does feel like a partnership, and that we're all trying to do the same thing. So I'm proud of the work that we've done. I can't tell you, when I go see my peers of commissioners all around the country, there aren't very many who have mobile crisis in every county in their state. So again, you all have generously funded a level of service that's remarkable, and I do want you to get the sense that it's working and that accountability continues.
I have a question for you.
Yes, please.
Thank you, Dr. Fitzgerald, Commissioner Fitzgerald,
Thank you.
for
Not a
being
doctor.
here.
If you're
Yes.
sick,
I represent 3 communities in Region 8, Taylor, Macon, and Dooley counties. Can you share with me a little bit about the level of service that that area of the state may be receiving? And secondly, as it relates to the crisis centers, are there actual centers that individuals can go to, or is the mobile units where people actually come to? If there's not an opportunity to make contact with someone that can come out, is there an actual center someone can be taken to in that area of the state, that region?
So you're
Tribute.
referencing Region 8.
Right.
Those are not DBHDD region lines. My folks are helping translate. That's Region 6 for us.
Region 6, okay.
Yeah, so.
Region 8 is from DCA, I'm sorry.
Yeah, no, that's okay. See, we all have our own language, right? So let me make a distinction. Where we have a behavioral health crisis center, that is an actual physical location.
Yes.
Okay? And That's separate from mobile crisis where they would come, okay? So, and let me say one other word. The behavioral health crisis centers were a new level of service delivery that was implemented as a result of the settlement agreement. Prior to that, and still in existence all around the state, are crisis stabilization units. Okay? Yeah, so, and that also is a physical location, and most of those have been in existence for quite some time. The challenge some of those crisis stabilization units have is that the physical building that they're in sometimes is not equipped to appropriately have emergency receiving. So that's why when I say that BHCC, Behavioral Health Crisis Center, those are designed for a lot more effective 24/7 and law enforcement drop-off. So, which, is different than crisis stabilization units where folks can go, but it really depends on the particular unit, what they can receive and what the walk-in capacity is.
So if someone has to call for the mobile unit representative to come out, any suggestions of what a person can do with that individual that may be having a difficult moment until the actual trained professional can arrive on the scene?
Yeah, absolutely. So, what's not even on here yet is our GCAL number. Let me be clear about that first. GCAL is the Georgia Crisis and Access Line. If you're in this room and you don't have this number, it's my last slide, so I'll keep it up for you. But that's our 1-800 number, 24/7, 1-800-715-4225, and those are licensed clinicians that are on the line, okay? They make the decision to deploy mobile crisis if needed. But if there is an active crisis, those licensed clinicians would stay on the line with the family member or the person that's calling. The last thing we want is someone in the community to feel like they're handling that alone. The crisis and access line is, but again, they're only, they're sitting there, they can't get there, but they could certainly stay on the line and talk with an individual who's watching or experiencing someone in crisis.
Okay,
Did I see another question, sir?
Thank you for your presentation and the information. I represent Floyd County, Northwest Georgia Regional Hospital, ergo some of the questions involved here. And also I have a law enforcement background, and I keep hearing from our jails, our sheriffs, about the increase in the population in the jails, primarily as a result. I know locally in Rome we saw an extreme increase, and you talk about the the crisis centers, and they're being maxed out. What percentage is now in jail beyond what is at the crisis center level? Can you address that?
Yes, we are going to have to address that, right? Because as Georgia, like every other state, is experiencing this challenge, when people don't get what they need, at an outpatient and at a crisis level, unfortunately for many people, the place that they land is in the jail. And once there, as you might imagine, for a person who's experiencing mental illness or has an addictive disease, the jail is not the place for those individuals to be. We share that. I know you'll hear from sheriffs later. We meet with the Sheriff's Association twice a year. There's no argument. We're actually all on the same side of this, which is that is not where folks belong, being in the back of a sheriff's car, landing in jail. The more we can do to get those folks out of jail, get them into the treatment that they need, that is what the shared goal is. But boy, is this a challenge. And in your region in particular, highly complicated by the opioid issue, which is an even bigger issue up in the northwest corner of the state. We've got some strategies and services and enhancement of that up in that corner of the state, but this is the part that we've got to figure out. How do we make more outpatient services accessible at the local level so people get what they need sooner and they don't land there? Because once they're there, we've all got a challenge together.
And you touched on it briefly earlier, but in following along with that line of thought, the staffing of these facilities, in terms of manpower, do you really have people available, or can you identify those that could be available to fill some of these roles and to expand the service?
Yeah, so I will continue to say, I think this is our biggest long-term problem, is the workforce to address the needs that we have. So we do have a number of pilot and other planned projects around that. One of the things that it's our effort to do is be a good employer. So making DBHDD and our providers a place that people want to work, that's critical. Even with that, though, particularly licensed clinical providers, starting with psychiatrists, also nurses, social workers, and other licensed clinicians, this is a problem around the country. We're at a point, I met with a bunch of private hospitals who asked me, could I get them some psychiatrists? And, I kind of chuckled and sort of said, actually, if I have some, I'm going to have them in our hospital. How can I be a better provider than you? We need more licensed clinicians. So this is a challenge, and we do have some long-term strategies in place, but we've got to do more to attract a workforce that wants to do this kind of work. But it really is a looming challenge.
Thank you. Please do.
Yeah. Oh,
I'd like to talk about the housing a little bit. You mentioned the challenges with group homes, no more than 4. Is that part of the justice settlement?
it is, and that applies only for individuals with intellectual and developmental disabilities. So that's the group homes for people who had to leave the hospital. They're on a waiver. That form maximum is what's dictated by the agreement.
Is there a waiver system in place? Because, one of the challenges we face is one size doesn't fit all. So what do you do in Clay County, hypothetically, when you only have one that needs it, or all of a sudden you've got a home with 4, and now you've got 5 residents that need that service?
Wait, did I already use what's my biggest challenge? I think I said workforce. Oh, yeah.
Do you have a waiver in that kind of situation, or are they moved while you're integrating into the community to another community because you're exceeding capacity?
Yeah, unfortunately, we do not have a waiver from that as it's defined for the individuals that are moving from the hospital into the group homes in the community. We've had extensive discussion with the Department of Justice, the independent reviewer in the case, and this has also really been a challenge about the fiscal viability of that four-person model. Unfortunately, we are still wedded to that at this time.
And finally on that, do they give you the standards in terms of the infrastructure of staffing as well as square footage and other things like that you must follow within that guideline?
So how it works now so the individual who comes out of the hospital or maybe comes off our planning list and has a waiver, that waiver really is your plan for individualized services. That's what dictates what the staffing plan for you is. So the provider might have 3 people that have, really we're trying to anchor, and this makes sense, right? Give the people what they need. What the person needs should dictate it. But it is quite a challenge because the fiscal and service delivery realities of that are challenging. I will say, I've got to compliment, there are an awful lot of providers who have figured out how to do this and meet the needs of the individuals that they serve. With these, in many cases, complex plans about staffing. But we're really trying to, the resources in the end are always limited. So making sure that folks have the right level of service delivery and right level of care when they need it, that's what's driving what the staffing pattern looks like.
So do they put that in, do you have guidelines you must follow
Yes.
in terms of staffing and square footage?
It's not in square footage. The staffing usually is more of hours of service and services that need to be delivered rather than square footage, if that makes sense.
Yeah, just on the crisis response teams, I've heard a lot of great things about that, but one of the issues that was mentioned to me was they have the great response times, but by the time they get there, that individual may be okay at that point. And then it's how do you evaluate that situation when that situation has de-escalated to everything is normal, and then that person is still almost teetering on the edge, and that family is there with, no way to deal with it, and then they leave, and it's just kind of that vicious cycle. Just wanted to hear your comments on that, and let the council hear that as well as one of the issues you have with that. And then also heard that the Albany facility had some challenges here in the past with just clients that had been through that facility and caused a lot of problems, and we're not able to take patients there through those difficulties. I don't know if that's true or not, but I know you have a lot of challenges, I guess. It's just.
Yeah, well, but I thank you. I think it's a fair point that's made. And y'all, we can all imagine this in our own lives, right? Where a person is in crisis, and then it's like a lot of things, right? When the problem solver gets there, it looks like the crisis has resolved. So there's not a need anymore to take up a precious crisis resource because the crisis right in front of you has, in fact, is not present anymore. But you raise a really important point. These are oftentimes people that really do still belong in our continuum of care somewhere. So how do we make sure, even though the active crisis is not present, that we know that there's a connection to the local community service that can provide it? I mean, that's on us, and we've got to keep trying to solve those challenges, because when the active crisis isn't there, the providers are stymied a little bit by what they can actually do. But at the same time, it's our expectation that certainly our community service boards and the other comprehensive providers are not walking away from that. They're picking that up as immediately as they can in order to provide services that are needed. I'm not sure about the Albany situation that you refer to. They certainly are one of our largest and most prolific community service boards here, and their crisis unit does stay full, as we would expect, even as large as they are. But I'm not sure if there's something specific that you're talking about, Representative Taylor.
Just one quick question, and it has to do with these, the behavioral health. Do you keep statistics on, are there a lot of repeat clients that you have that continually go into crisis, or are they new people? I'm just curious if you do follow that, and has it perhaps been affected by the closure of the state hospitals?
So yes, we absolutely, that's a really important piece of information for us, is understanding who these folks are. Have they ever been served in the state of Georgia before? How can we get them to the right solution? So that is very important information for us before. We don't look at it through the lens of, were they hospital patients before? It really is, what's their local connection? Have they ever? It's important for us to know how many people are coming into our system first through the crisis door, because that really tells us how can we do more, or it really pushes us to say, how can we do more outreach? How can we find those people? Entering through our crisis door is not the way really we want people to start their service delivery system. But all of that data is critical to us. And I do want to say one other thing. Many of you heard about this for a long time. Our administrative services organization, this is going to sound like bureaucratic speak, but our partner, the Georgia Collaborative, and our partner in this work is Beacon Health Options, who provides services in other states as well, and that they've been able to bring some new ideas to the data collection and management of our service delivery system. 5 years ago, and I can say this because I was a provider, working with Commissioner Berry at Viewpoint Health. We submitted mounds of data to the state that seemed to us, when we were providers in the community, went into a giant black hole. Now, the accountability around the service delivery system, partly through the implementation of this ASO, is tenfold. Each provider has key performance indicators that we're tracking, and they're the critical ones about are you meeting the basic standards? And where you're not, how can we work with you to have a corrective action plan? How can we help improve? What kind of technical assistance can we or somebody else provide? The amount of information that we have now is so far exceeds what we had in the past, and it really does drive our decision-making. So in our behavioral health system, to be clear, we've got very active utilization management and oversight of that data. We're just building that in the intellectual and developmental disability system. So some of the questions you're asking about the individuals and the waivers, we'll have more of that same level of aggregate and system-level understanding in the next 2 to 3 years as we build that. It's critical. We've got limited resources. We want to use them right. We need that data.
Commissioner, thank you for standing in the hot seat, as it were, and thank you for taking these questions. This is a tremendously important part of the conversation in rural Georgia. And while we're on the behavioral health, before we get to the opioid, one of the things that you mentioned, and I appreciate you doing that, you don't want the first interaction with a patient to be at the one of the crisis centers. If we could catch problems early with mental health disorders, one of the most underserved communities, and in this same frame of mind, we will see in our public school systems, in elementary and middle schools, not just in the high schools, of kids that have been exposed to pretty awful things at home and in their communities, that are facing depression, and they will get worse, and they will be seen in the crisis centers unless they can be seen before one of these crises takes effect. And, it's not anything, I know you've already mentioned, we need more staff, and need more psychologists and psychiatrists, and we need more of those providers. But one of the things as our council looks at this issue that we do not need to forget is the kids, and finding a way to treat these kids before they become a problem in their communities and in society. And if we can catch them early, then we have productive citizens. If we wait till they come into a crisis center, then we have a liability on our hands.
Yeah, thank you. So thank you. I'm glad we have a moment, because I do want to say just a little bit about children and adolescents, because this is so important. And again, y'all in the rural areas, it's just even more challenging for you because of the stretch on the resources. I want to say something that in some ways will open a Pandora's box, but it's important that we talk about it, because what kids have available to them in terms of mental health and anything else really is determined by their payer source. And this is language we all, in talking healthcare, have to start getting a little more comfortable talking about, right? So like all of us, or many of us, I assume most of us in the room, you have an insurance card, right? And when you have an insurance card, that's your payer source, and that dictates the package of benefits that's available to you. The same is true for kids. DBHDD's responsibility is uninsured youth. And frankly, the way things stand right now, there aren't that many uninsured youth. So what determines what a kid has access to, first and foremost, is dictated by their insurance package. I would like there to be as robust an array of services available for kids, just as you mentioned, to prevent early, to access, so that kids can access what they need as quickly as possible. But this is a way we have to start talking about it, is that kids do need access, and schools and other places are where those troubles show up. But what we're trying to do is partner with folks so that people understand how do they get the array of services that's already available to them, and holding the right elements of the system accountable for delivering what's within a benefit package. So I say that. The other thing I'm really excited to tell you about, I think y'all know the Children's Commission on Mental Health has been named, and I'll be co-chairing that with Katie Childers from the governor's office. And this is exactly what we're going to tackle, which is, if there were funds to be brought into the state for kids with mental health needs, what are the gaps how can we prioritize the gaps that we need to fill, what's needed? I believe firmly, I've been a part of, and there have been many commissions on children's mental health needs. I believe there is a desire right now to say, let's make some priority things happen. And so I'm excited that I believe there's a real opportunity ahead on behalf of children and adolescents. Thank you. I think one of my team members wants to add something. I always say yes if they've got more information.
You talked about children in schools. Our community service boards have what's called the APEX program, the GAP program, and they are in just about all the school systems where they're serving those later, but it's a really great program. We're really, really proud of it. One of our local providers was actually recognized a couple of weeks ago at the Georgia System of Care Academy as the statewide lead on this, and that's Georgia Pines here in Thomasville.
So thank you, Jennifer. I hope everybody could hear that, and I appreciate you mentioning what we call the APEX program. And there already have been several children's commissions that have said more of that, expand more of that. And I can tell you for myself what's different from 10 years ago. 10 years ago, as much as there were needs that existed, schools didn't want mental health in their schools. Now, people are clamoring, and they're saying, how can we get access? We're ready now. We want to make this available within the school setting. How can we do that? So the department is absolutely poised to expand. I anticipate that the commission will look at those recommendations that have come forward, because there's been such a positive response about having services available in the school. We have teachers, we have educators. They want help, they want partnership, and there's a willingness now to really implement things on site at the schools.
Commissioner, again, as it relates to the community service boards, is there a map that we could review that shows our area, which service board service our areas?
Yes, so
Okay,
I'm going to refer you to the DBHDD website,
Okay.
which has good information. It shows you our 6 regions, and then it shows you the coverage area for each of the community service boards. And then I think, David, please let me know if I'm correct. We also have crisis locations. There's a section on the website that now says for law enforcement. We are trying to make information as accessible as possible, so that if you're law enforcement and you're trying to figure out where is the closest crisis, it's also notated on the map so that you can see. And there are phone numbers listed and contact individuals, so that you should be able to get easy access to who you want to call.
Okay. And one other question, you mentioned about your, you all have been presenting to the sheriff associations.
Yes.
Have there been any communication or presentations at the school board associations, since we were talking about children, mental health, and being connected with the school system? Have you all had a chance to really work closely with the school board associations across the state, perhaps?
So I think locally, there have been, in many communities, there is a team at the state, it's called the IDT, Interagency Directors Team, and that is all the agencies and a lot of other partners that serve kids meet on a regular basis and determine priorities, and then many of those members have local elements, and there are also something that's called LIPT, Local Interagency Planning Teams, and in many local communities, not every, because they're variable, but that is the place where all the people in the community would come together and really talk about some of the most challenging kids in the community. So I don't know about your particular community, but there is quite a bit of local effort that's really run by local experts who know what's available.
Okay, thank you.
Spend a few minutes and talk a little bit about opioids, because I do know it's of interest to you all, as it is to everybody, and certainly a pressing challenge for all of us. So as you see there, a little bit of Georgia information in 2015. 1,307 Georgians died from a drug overdose, and the numbers right now are saying that 68% of those were due to opioids. That's a 10-fold increase in prescription opioid overdose between over a 15-year period. Look at that, y'all. I mean, we know this in our communities. This is really just mind-boggling how this is a wave across the nation. And I think the concern and the notion that it's an epidemic is warranted. In Georgia, the state of Georgia has a lower overdose rate than the rest of the country. But 55 counties in Georgia are above the U.S. average. And those are some areas that we're interested in looking at and certainly building some more supports for. So I think what y'all may be aware of, at the federal level, every state was awarded dollars to address the opioid epidemic. So in Georgia, We were awarded $11.8 million for 2 years, $11.8 million each year. And this is an overview of the 2-year grant that is already underway. And as y'all are very familiar with, anytime you get federal grants, you get very specific parameters about how the money can be spent. So DBHDD is what's called the single state authority, so we had to be the applicant. We were the recipients. The amount that each state got was really population-based. So I've heard comparisons with other states, but that was really already determined at the federal level. Question, sir?
Yes, ma'am. Can you go back to the slide? We were talking about 55
Yes.
Georgia counties above the U.S. average over, that's right. Has there been anything that you've looked at that shows like maybe a cluster of counties or certain areas or anything like that?
So a couple of things about that. It's a great question. So the general description of those 55 counties are southeast and north. But we are working really closely with the Department of Public Health, right? Because as you start to look they're the experts in population health. And so really, this opioid epidemic has been a place where we've been able to come together with public health and say, how do your data collection systems, at that public health service delivery level need to coincide with ours? So we are looking more deeply into what does this information tell us. I can't tell you anything specifically yet, but I do think you can expect that we'll know more as information unfolds.
It might be helpful to look at the whole overall picture. I'm glad y'all are doing that.
Yeah. It's critical because there's limited resources. You got to apply them in the right areas. So the good thing about the grant money as it is it touches all of the areas. It touches increasing access to treatment, reducing unmet treatment needs, and there's a prevention component, a treatment component, and a recovery component, and all of those are essential if we're going to have an effective response to opioids. The good news was that, so the work is underway, as you can see, year 1 implementation, June 1st, 2017. Our addictive disease team already had a strategic plan well before we knew the funds were going to come. So already there was a plan laid out. It wasn't like we had to scurry to gather everybody. Folks came together, we did have a plan, and then this determined, the feds determined how the money was going to be allocated. So as you can see there, and as I mentioned, it's $11.8 million a year for 2 years. At least 80% of the money has to be spent on opioid use disorder treatment and recovery support services. So we're interested in prevention. Prevention's critical. At some point, you've got to get ahead of the crisis. But at this point in time, the feds were very clear. You've got to use the money for treatment. And as you see, up to only 5% of the award can be used for administrative and infrastructure costs. So I get it. We need treatment. So this makes sense. Yes, please.
Just a quick question. You noted that it was like 10-fold increase in the prescription opioid.
Yeah.
Is anything being directed to the providers that are writing these prescriptions?
Yes, so that's another ongoing conversation, certainly with our partners at Public Health and others about how can we monitor prescription writing and how can we have some effective systems that can do that. So I'll give you a quick overview of where all the money's going and then a little bit of challenges that still remain. So part of what we have is we wanted to have increased access to medication-assisted treatment. For Medicaid-enrolled individuals, we expanded our network to make medication-assisted treatment more possible. And then, as I mentioned, we've also got an active partnership with public health and, of course, community health, right? So where Commissioner Berry is now, we talk on a regular basis about what does the network look like? What is the network, which includes providers of all kinds? How can we monitor the performance of what's happening? And we're at the early stages, but that's critical work that needs to be done so that we can intervene in the right place. So as I mentioned, the bulk of the funds are going towards treatment and recovery, but there is an interest, as you would expect, in making more information available and continuing to expand a statewide media campaign so that people understand about misuse and abuse of opioids. And so educating the public, reducing stigma, making it possible, you see through promoting the Good Samaritan law, wherever possible, letting people know you can get help. You see, I do think, and I hope you see some ways in which media attention and information being available has made it easier for people to say, I do have a problem, how can I get help? We have a number of public service announcements. Y'all may have seen us in movie theaters and other non-traditional places to really make it known to folks that information and treatment, what the problem looks like and how you can get help. So we've expanded our detox capacity and the residential bed capacity, right? Because when people need treatment, there's not a quick fix, as y'all know. So, I mean, this is part of what we have to talk about with this kind of epidemic and the intensity of this challenge, that the solutions are not easy and they're not quick. So there's a whole array of things that we need to do. So increasing the residential bed capacity, providing training on what's best practice as it relates to opioid use, and providing the Medicaid-assisted pharmacy benefit. I think y'all are very familiar, and there's been a lot more knowledge and awareness now about naloxone. The governor spoke about it in his address, State of the State address, making Narcan available for first responders. And as you see, there are ambulance drivers, emergency room professionals, firefighters, and our community service boards. And so Narcan is a tool in the toolbox, right? But we all want to be talking more. Narcan, if you're using naloxone to stop a person who has had an active overdose, we've reached the last point, right? What we want to talk more about is all the things we can do in advance of people being addicted and it leading to overdose. But certainly as I meet with my colleagues, commissioners in other states, the pressure around how to address this issue in statewide in a comprehensive way, this is really quite a challenge. I do want you to be aware of one of the things that has been found to be effective, which is really using peers in the treatment continuum. So peers are what you would expect they are. They're people who've been through this and are on the other side of their own addiction and treatment. And what we find is that for a lot of people, talking to a professional is not always the solution. Sometimes talking to someone who's been through it. So making that available through emergency departments, through warm lines, through other ways, really sometimes is a better door into effective treatment. So we've enhanced our ability to hire peers and other individuals that can provide a different level and a different point of access into services. And you see, so the activities we have there are a warm line. So that means kind of what you would think it would. Person needs help. Not maybe at the level of crisis, they need someone to talk to. A peer being on the other end of that call really has been shown to be effective. Having peer specialists, people who are trained to do this work actually in ERs, and a host of training and education events throughout the state. We're also targeting kids, children and adolescents with some of the funds that have come here. We've got the there's a strategic prevention framework put out by the feds, and so basically this is the implementation of this. We've got a pilot program that is really around drug prevention and other prevention activities. I just want to say this. All of that is not going to be enough. We're going to have to do more. We certainly, like many other states, are hoping that there are more funds coming down at the federal level because the providers, where the first wave of dollars went out, because of the short timeline of the grant, We had to build on where there were existing providers. So that's good. We expand where we've already got some momentum. We've got trained individuals. But what you all will hear, and what I know is true, is there are still gaps where we do not have enough services, we don't have enough beds, we don't have enough, we need more. You'll hear more about us asking for more money, and we really hope that there are more funds coming down at the federal level, because there are certainly areas in the state where we simply have to have more response available. So, yeah, you certainly will hear more about that. Put up for you what always, we want to make sure people have available, which is what to do if there's a crisis, and call that number. And certainly our expectation that 24/7, there should at least be a response that at least gets you on the right path. I don't know if yes, another question?
Thank you, Commissioner. I appreciate what you've done, and especially what Commissioner Berry did. I know that this has been difficult working with feds, especially under the last administration. So first question, we have a new administration, we have a new department that you're working with. I know there haven't been time for the lawyers to all change and all. Are you seeing any more willingness to work with you on things?
So thanks for the question. We do have, July 7th, we had our first parties meeting, the parties in the agreement, the state and Department of Justice, in the new fiscal year. All of the targets in the extension agreement go through June 30th of 2018. It's very aggressive targets. I will say there is a new lead lawyer for DOJ. I can just tell you about this meeting in July. There used to be 6 lawyers that would come into the meeting. This time there was 1. I feel like there were very clear and direct questions about how are you doing against these targets, and I feel like that's a fair way to work going forward. I hope that that continues.
Okay, good. I'm glad to hear that. Not always do bureaucrats in Washington know what's best for patients.
Agreed.
And especially in individual states and what individual states can provide in a quick manner. So I know that you and Commissioner Berry have had a difficult time in implementing this program. I've been watching it as it's gone along and hearing about it. Second, I want to drill down into the workforce. Physicians are not coming out of residency programs at great numbers in psychiatry. I don't know how we change that, where all the states are fighting for them. But what is the problem as we go down? I mean, you hear a lot about kids coming out with social work degrees, with basic degrees in psychology from BS. Are they too, and I'm a psychiatric nurse, so I think I know the answers, but is their training too general in these areas to come in and work in these situations right away? Is that the problem?
So the problem is complex. I really appreciate your appreciation of it. One, it's hard work that we ask folks to do. I think that that's really true. And frankly, the pay to work in our system for some is not as appealing as it might be to do other work. So one of the things that's a big part of what we're doing is also how can we work differently. Telehealth is a part of the future, that's critical, but also how can we deliver services in a way that maximizes what the capacity is.
Okay, is this something, as we push our technical colleges, if you have a basic degree as a social worker or a basic degree in psychology, is this where a program could be developed in a junior college, like where they get a certificate in working, in this basic level, not a master's degree or all, but a basic certificate of dealing with psychiatric patients where they maybe go back for 3 months or maybe longer and work toward getting that? I mean, has there been any discussion with our technical colleges about anything in this kind of program to specifically train? I mean, for years I've said we need to have, a program where we train nursing assistants with a couple of extra months on how to take care of the elderly. Well, if you have these basic degrees, and lots of kids are getting them, and it's my understanding they're not finding jobs. Have we been in talk with our technical department to try to work in some of these areas where you're so desperate to maybe come up with some kind of program that might give you entry-level, better trained people to do some of these basic entry-level assessments and all.
Yeah, so I think you raise a really, a possibility. We're open. I think the workforce challenges of the future are bigger than any current solutions that we have, although we do have some underway. I will say, certainly in our hospitals, there are a number of tech-level social workers that do the frontline work in the hospitals. Some of that is true in the community, but when you get to the higher order clinical work,
Right.
then we don't have it there. But I think you raise a good point about what else is possible, because we really are going to need to expand access in some way.
Well, I think that you too find if somebody has some basic training, you got a BS in psychology, and maybe you could take some of this, you find that you're very interested in it, and then you're willing to go back and work on a master's
Yeah.
to gain other clinical training when you find you really do like the work and that an advanced degree is more effective. My third question is back to disabilities. It's my understanding that our death rate, and I'm sure it's one of the reasons you put a halt on how quickly we were putting people back in the community. People are telling me that the death rate went up significantly when we were moving severe cases of our disability people out of the hospitals at first. And I want to know if that has significantly decreased now that we're doing it on a slower basis. And I know the kind, I'm not pointing a finger, because I know the kind of people that we're talking about. Very medically fragile and very difficult, to keep stable. And so I'd like to know how we're doing on that, on the death rate, and, lowering that death rate number of people coming out
Yes.
and going into the community.
So, DBHDD produces an annual mortality report. Where I believe in August, we'll have finalized this past year's annual mortality report. It's really good. We'll post it online when it's
Okay.
available. The question that you raise is very complex. It is obviously of the highest importance to the department.
Sure.
The safety and well-being of the individuals, particularly those who leave the hospital and come into the community. All the additional things that we put into place for better response and more enhanced oversight and connection to the community, I do really believe has had a positive impact. I can't speak to the death rate in the way that you're asking it,
Okay.
but I do think it's important that you know that we're looking at it. You certainly can look at the way that information is calculated and how challenging it is to compare state to state, but do know that it is a high priority for us to really understand what folks need to live a successful life in the community.
Well, like I said, I'm not pointing any finger, because I know what kind of patients these were and how fragile they were. And this is one of the areas where I'm saying bureaucrats in Washington don't always, know what's best. Sometimes there are patients who need that in-hospital care that are just not going to survive out in a community setting. And so that's what I was talking about, hoping there's a little more working with new people and letting us do it slower and where we go forward with
Our
that.
goal for the agreement, there are very specific targets that are in there, and you can see them on our website. The extension agreement is posted. But I will stand by if we are doing something that is transforming and improving our system, the target is the target. I really want to show that what we're building is sustainable, and I believe that it is. And I'll resist if we don't meet a target, but what we do have is a sustainable system that in the long haul can really provide people what they need. That really is what I believe our work is.
Well, just let me know if you run into difficulties, and I'll come fight them with you, because
Well, thank you.
this is a very difficult area with our most vulnerable citizens, and we just need to be realistic about what we're doing.
Thank you. I believe Georgia's made more progress, but again, I want to point back, it's because of the investments, the willingness, the commitment, and I want to honor that. I really think we're going to get there. The system transformation is real.
Commissioner, I've got a quick question, I hope, before we take a break. In rural Georgia, I think probably one of the biggest challenges that differentiates the rural part of the state from the other part of the state is the lack of access to transportation. And specifically when you're trying to make sure that people are taking their medications and they are reluctant to do that to begin with, so it's not like that they've got a real strong incentive to reserve a Medicaid bus or whatever it may be. Is there any effort on the part of the department in rural Georgia to be more proactive, as whether it's making house calls or basically taking the first step rather than waiting for somebody to miss 3 appointments and then they're in crisis because they haven't been taking their meds?
Yes, so in one of the earlier slides where I had a list of all the services that came really as a result of the settlement agreement, you saw some things. I mentioned the assertive community treatment teams. Those are for the highest level of need. What I hear you talking about is a little more, maybe folks that are below that level, right? We have case management and community support teams that are really directed a little more towards rural areas where the idea is before crisis, how are we proactively staying engaged? And I think that's certainly part of the what we measure the community service boards and our other providers is their ability to stay engaged with the clients that they have, to do the basics. But I think you're correct in noting that transportation is a challenge for everybody to overcome. But for things they can do on their own, we do want to have that proactive engagement where somebody's reaching out to them. Some version of that, there are some elements of that do involve house calls, as you might call them, but I think it's harder. Yeah, it is true that it's harder in the rural area.
Thank you, Commissioner. And we're going to take a 15-minute break.
Thank you for the opportunity. Really appreciate it.
organization in Miller County and what we've done to still be viable today and continue to add value to our community and the patients that we serve. So just talking to you a little bit about some of the broad spectrum of services that we offer now. We are a critical access hospital. How many of you are from primary care or hospital services? Anybody in here? Okay, a couple people. Yeah, there you go. A couple people. So we're a critical access hospital, and there's some criteria that you have to apply for in order to get this specific designation. Generally speaking, we're in rural communities. Our county is our county is a county of about 5,200 individuals. When I first came here, there was over 6,000. But we're seeing an erosion of our population like we're seeing in most areas of the South. But we're also seeing a widening gap that's going on in our community. So we've got outward migration of our younger people, and what's being left behind are our older citizens, those that are the most vulnerable and in need of medical services. So a critical access hospital is typically in an area like that. And that's really the big debate or concern that not just the state of Georgia, but nationally is going on as we see an erosion and a closure of these rural hospitals. Some of our most vulnerable citizens are the ones that are sitting there, deserted without healthcare access. And so, I applaud all of the efforts that's going on to try and look at mechanisms, transitions of care that maybe can still be surviving in these rural areas when some of us have disappeared from this planet. So some of the services that we offer is, we're going to talk a little bit more about a ventilator dialysis program here. It's a very unique service. We're the only hospital in this region. Outside of our particular program that we operate, the next closest facility that can handle this type of patient is either in Illinois or in New York State. I'm not exactly sure which state is closer, but that would be the next closest receiving facility to handle patients that are needing this level of care. We have an emergency backup generator. What's the big deal about that? Most rural hospitals have them. We have two. So we've got duplicate services that cover all of our nursing home and all of our hospital. It's something that I felt very strongly about years ago that we needed to do. Post-Katrina, we all saw what happened there, and I felt real strongly as the incoming CEO that we needed to protect our individuals. People who were going to seek shelter, who needed shelter. You know how many people are just in their homes on CPAP machines, dialysis machines, all of that kind of thing, just general respirator kinds of equipment, people with Guillain-Barrés. Those people need shelter, and I felt like we needed to do that. In 2014, we migrated to the Cerner health information system. It's between them and Epic. Those are the two biggest health information systems that are out there. And then we also use another integrated electronic health system in our nursing home. It's called Matrix, and the two of them are completely integrated. We have a pharmacy that is on call 24/7. We right now staff 5 full-time pharmacists. Can you even imagine that? In a critical access hospital, by the way, that can only have a maximum of 25 beds, we now have 5 full-time pharmacists employed with us. Our radiology service is open 24/7, as is our laboratory. Typically in critical access hospitals, these services go on call after hours. I felt very strongly that we needed, and actually when I first came there, the services were on a call system, but I opened them up 24/7. We do some surgery, we do some general surgery, we've done some gynecologic surgery, still do some of that. We do pediatric dentistry, not so much as that because the pediatric dental program or practice that we partnered with, they've got a staffing problem right now due to the loss of a dentist, so we're hoping to bring that program back on board, hopefully within the next year. It's critically important for the people in our community. And then we also offer podiatry. So in terms of surgery, it's kind of that bread and butter thing that you would think of. Obviously, we provide anesthesia services. We offer a care management program, which we'll talk a little bit about. We provide pharmaceutical assistance to indigent, to people who are uninsured, underinsured, or just in need. We do some limited telemedicine. Primarily, we do that with psychiatry. We have respiratory therapy on site 24/7, dialysis in the hospital, plus we opened up a dialysis clinic a couple of years ago, pulmonology, nephrology, psychiatric services, infection control and antibiotic stewardship program that we've been running for about 4 years, rehab, wound care, all of those kinds of integrated services that are necessary to run the infrastructure that we've developed, and an accountable care organization that we started about 1.5 years ago with care management of insured and uninsured patients. And we'll talk a little bit more about why those are so vital to who we are today. All of these programs, none of them happened overnight. They're all new programs since 2008, or they are the genesis of programs since 2008, and all of them as an integrated part made us who we are today. So just a little bit about the economics of our area. And I do consider Baker County, which is contiguous to us, I consider that a county of concern for us. Calhoun County, a county of concern to us, and then Miller County for obvious reasons. These are the demographics of the counties that I consider that we serve. Probably, really not unlike any other rural county. The poverty level in these areas, are obviously leading to several of the comorbid problems that we are all dealing with, leads to the fiscal viability of the county, of the hospital, et cetera. Transportation is a huge issue in these rural areas. So, okay, Terry mentioned that I'm not from here. Okay, that is kind of a no-brainer. Have you figured it out now? So I come from New England, and I was born in Providence, Rhode Island, and I lived in Boston all of my life. I mean, the thought that there would even be a household in any of the areas that I lived in for the first 30 years of my life without a motor vehicle, we never saw that. Even with poverty, we didn't see in some poverty-ridden areas, we never saw areas or homes without motor vehicles. Here we all live it, we see it. So there are the demographics, and again, not unlike what you all are probably seeing in the areas that you live in. Education, another huge barrier that we're all suffering from. We heard a presentation just a little while ago about developmental disabilities and getting people into behavioral health programs. As you're going to hear later on, the education and the workforce that we can even develop in these areas to help us with some of these programs is, to say the least, difficult at absolute best. Our hospital, again, critical access hospital, 25-bed. We've got 4 family practice physicians, 1 family practice, he's an FPOB. All of these physicians really are employed by Miller County Hospital. So the 4 family practice physicians are employed by us. The FPOB gets partial support. He's not full-time employed by us. He's a family practice guy that came out of the Phoebe residency program probably about 12 years ago. Good physician, tried to be in practice all on his own without any support, and without us helping him now, his practice would have closed and he would have had to flee the area. A private practice guy just on their own, I mean, they just cannot make it. So I realized that several years ago and offered him a stipend to support his practice. Quite honestly, it's less expensive for me to just support them than to employ them. So that was my motivation. We have, in our emergency room, we staff it with mid-levels, not MDs. We use PAs, physician assistants, and family nurse practitioners in our ER. We have three in our ER in total, and then in addition to that, we also employ, in our primary care areas, we also employ 2 family practice NPs, nurse practitioners, and 1 PA. So in addition to all of the physicians that we employ, we also employ a plethora of mid-levels who really, to be truthful, as long as it's segregated duties, they are the workhorse of our organization. And then we also have, obviously, pulmonologists and nephrologists working on our staff. Just to give you a little bit of background then, financial performance. In 2007, now before then, the hospital had, just to give you some history here, and kind of where I walked into, and Jimmy Lewis was one of the first people that I reached out to when I first got there. But we had successive years of multi-million-dollar losses in Miller County. That hospital authority borrowed up to the maximum that they could possibly borrow for. And once our property was, once the loans were held against our property and we had nowhere else to go, then collateral was our accounts receivable. And that, quite frankly, wasn't worth the paper that it was written on. So I came into the hospital in 2008. Our fiscal year ends June 30th. I came there, I believe, on July 5th. So right after our fiscal year 2008 started, and the hospital had at that point in time this is actually wrong, fiscal year 2008 ended with a $1.5 million loss. From the prior year. When I came in, there were 30 empty beds in our long-term care facility. The nurses in our nursing home, really, they couldn't even start an IV. Their skill sets had been so eroded that our nursing home became more of a custodial care program. The management, or the prior CEO and the hospital authority, was really focused on creating a medical center look. And as a matter of fact, there really is, with the state of Georgia, some Miller County Medical Center thing that's registered out there. They were interested in competing against a Phoebe and a Southeast Alabama, and quite frankly, Dr. Story, probably even Archibald back then. So, you know, to me, that was delusional at best. That's what I walked into. They had just lost another $1.5 million, and this is where the facility was focused. Not redirecting their attention to where it really need to be. So it was July 10th that I actually came in, and I remember on my interview with the hospital authority, they had asked me if I thought that I could help them, and I just looked at them and I said, well, yeah, I think I can help you, but you have to be willing to change. If you are not willing to change, then nobody's going to be able to help you. You're a 25-bed hospital with 8 patients in it, 30 empty beds in a nursing home in a county of 6,000 people at that point in time. You got a hospital up the street with 12,000 people in their county, 25 beds, and they're suffering the same thing. So why, you know, in this country, why do you think you would be different? I mean, we all know the definition of insanity. Okay. So I said, you've got to be able to change. They offered me the ability to do, you know, in free reins pretty much. I guess at that point in time, they really had nothing to lose. They offered me free reins with whatever it is that I felt like I needed to do. By fiscal year 2009, shortly after I started, one of our bankers called a $3.5 million note due. Now, I have to tell you, you know, this was 8 years ago, and when I think about it, I still feel like I get a little flushed because we didn't even have $100,000 in the bank. And here came a banker saying, I need our money. and I had nowhere to get it. But obviously, we very, very quickly, immediately, pretty much right after I started, focus got redirected into our long-term care facility and trying to refinance our existing debt, which at that point in time was, well, with that one bank was $3.5 million, but it was well beyond that. We had negative liquidity of about $7 million. So we had negative net worth. Welcome to my world. I went to HUD and said, okay, I got to find some money somewhere. Clearly, we're not going to generate it ourselves. Where do I go? So I went to Housing and Urban Development. Barack Obama had just become our president, and I really thought, oh my God, he's going to be my savior. He's somehow or other, this is going to help. Because he gutted about infrastructure. But unfortunately, you have to be a going concern even to get refinancing funds. So really, nobody wanted to hear it from me. One of the things about critical access hospitals are we are cost-based for Medicare and Medicaid on an outpatient basis. So using that, and directing our attention to focusing on long-term care, developing a census that was appropriate for critical access hospitals was critical to us. By 2009, I looked at how do I fill our beds, both in our nursing home, which ultimately can feed my hospital. And so finding a niche market for Miller County Hospital was absolutely critical. And when I looked at the number of long-term care beds in the South, and you could do this today, any one of you could do this yourselves today, because this data is just from last week. Within 25 miles of the center of Miller County, there is one long-term care bed available for every 8 people over the age of 65. One bed available for anyone over the age of 65. When you go to the center of Atlanta and look at 25 miles out, you find that there's one long-term care bed for every 14 people. What does that tell you? There's 2 daggum many beds down here in the South compared to the Atlanta area. Now, that's my own personal prejudice. If Department of Community Health was in here, I wouldn't admit to that, so Commissioner, Mr. England, please don't repeat that. But then don't write that. Okay, so what's the niche then that will help me fill these beds? Was obviously a great concern. So we focused our attention into a couple of different things. Finding that niche market for ourselves. The other issue for us was reducing our bad debt. Where does it all come from? It comes from our emergency room. For the most part, it comes from our emergency room services. Some of it comes from mental health, patients using mental health access, in the ER. Some of it comes from people not having access to primary care or not having insurance and just being embarrassed about walking into a doctor's office and trying to get primary care when they don't have any money to pay for it. So they end up, and then some of it is just purely bad behavior. And we do have a lot of bad actors out there. So let's look at, as an organization, let's look at decreasing our bad debt, reducing the bad debt through care management, and managing those patients who are using the emergency room inappropriately. The people who come in, at 4 or 5 o'clock in the afternoon and have an earache, they've had a cold for 3 days, but they want to come on in because they don't want to go over to a clinic. The patients who have dental caries and don't have access to a dentist, maybe they only have Medicaid and there's no dentist in the area who's willing to accept a Medicaid patient. You would be surprised at how many of those patients walk into your emergency rooms in your communities. Maybe it's somebody who's got suicidal ideation, and a hospital in an emergency room, at least ours, was totally unequipped to deal with all of these problems. So one of the first things that we did is we hired an LPN and placed her in our emergency room to look at all of the patients who were coming in who had chronic diseases or who were just misusing an emergency room and were at the wrong place. We also partnered with Spring Creek Health Cooperative, for anyone who's familiar with them. They've been around for probably about 17 years, I guess. It was an initiative that was formed. I was with the Archibald organization. I know Rick Ivey was here a few minutes ago, but helped to put together this cooperative, which is an enabling services that deals with people without health insurance or inability, either no insurance or underinsured, and trying to get them access to medication. So we partnered with them. We also opened up applied for a retail pharmacy license, got that, and then we began dispensing medications to our long-term care facilities. Now, why was that important for us? Again, it's about loss, and we had a pharmacy, hospital pharmacy, which when we got a retail license, we could begin dispensing ourselves to those individuals. When you have a nursing home at that point in time, even though there were only 65 patients in our nursing home, the average nursing home patient at that point in time, years ago, had 13 prescriptions, okay? And those prescriptive services were being sent to retail pharmacies in the area for them to fill. That was an opportunity for us to capture some of that. The other issue is if it's what's called a Medicare stay, guess what? We had to pay for those pharmaceutical drugs for those 13 prescriptions, whatever the heck they were. So getting a retail license or filling prescriptions for us was part of it. Just in that 1 year of putting together bits and pieces of these programs, we reduced our uncompensated care by 1 percentage point. It went from 20% down to 19%. That had a $200,000 impact to our bottom line. Just putting in a few of those programs in that very, very first year. And understand, it was the first year. We didn't even have a full, by the time I got going with some of this stuff, I mean, some of them had only been in effect for 4 or 5 months, others of them, up to a year. By 2010, we continued to have a problem with our emergency room and patients still using that ER inappropriately, despite the fact that I had an LPN in there just dealing with those chronic care and bad actors. So we operated, and still do, operate a rural health clinic. We increased the sliding scale fee for that rural health clinic up to 200% of the federal poverty line. Basically, most people on any given day in our community, except for my employees, could walk in there and qualify for indigent care or financial assistance programs. So we increased their access to free care. We also renovated our rural health clinic because as we redirected more patients out of the ER in there, the first thing we realized is, oh my God, we're out of room. We don't have enough physicians, enough office space, enough exam rooms for these individuals. So we renovated our rural health clinic in 2010. So now I've got an influx. I've increased our free care access to our community. We've got more patients coming in there. And what's that doing? It's reducing then the cost of care in our emergency room as we migrate through all of this. At the same time, it's a critical access hospital, Medicare, Medicaid, cost-based reimbursement, okay? For those of you, Dean Burke back there, who comes from a healthcare background, that means, it doesn't mean that we get, that we get any perks. It just means that we're guaranteed the cost of doing care, providing care for a Medicare and a Medicaid individual, just the cost. So how do you make up for the loss, this $4 million of free care and bad debt that you're giving to the rest, really, the rest of our population in rural America. They're either Medicare, Medicaid, or uninsured. So if you're giving away more services, how do you make up for that? Well, the opportunity is, obviously, we've got to get more insured people in here. Well, I hate to tell you this, hate to admit it, but unlike Thomas County, Miller County isn't exactly the epic of commerce, okay? So we don't have new businesses flooding our gates to come on in. And what does new business bring? It brings a new payroll. It brings health insurance that a hospital needs. So I went out and said, okay, I need to go to the few businesses that we have, and it's the school system, okay? It's the school system, it's Birdsong Peanuts, which, by the way, is right behind me in the number of employees that kind of ticked about it because we've surpassed them. But Birdsong Peanuts, our school system, our sheriff's department, our county, those are the businesses that have insurance. So what I did, and I'll show you examples of this later on, so what I did is I got to get those people to want to use me. I've got to, and they're going to offset some of this free care that I'm doing. So we created a card for them that was tailored for every one of those businesses that offer free care for your employees who are sick. They may come, and listen, any of you who run businesses around here, I'll be glad to do it for you folks as well. Okay, so we offer to their employees, you can come to 3 visits a year in our rural health clinic, and I will not charge you. Okay, so why do you figure I did that? The stipulation is you got to be sick. Because if you're sick, I'm going to guarantee you that I'm going to also do some blood work and some x-rays and things of that nature. And I might even write you a prescription. And that ain't part of the game, okay? So what I was trying to do is get some of that goodie into our system.
Would you explain that again?
Sure. Okay, I would. I have copies of cards. So who are you, sir? You're a House representative?
I'm from Sandersville.
Okay. All righty. So if you ran a business, or you were the principal at your local high school, or you were the school superintendent, this is how it works. By the way, in 2 counties for us now, Calhoun and Miller County. So you run the school system. I simply go to you and I say, Dr. So-and-so, I'd be glad to offer free care to your employees. You have to give me a roster. I do a presentation to them. You give me a roster, I will create a card, an emblem that's just unique to your employees only. And if they get sick, I'm going to give them a free health examination at our rural health clinic when they get sick. And the bonus to them is your health insurances really cover wellness visits. But the part that everybody really is lacking is sick visits. So I offer them 3 visits a year to either them or their immediate family, as long as they live in the household. Doesn't matter to me. And I don't care if you're a school bus driver. I don't care if you have insurance or not. I don't care if you're a school bus driver or a dietary or you're the school principal. You come on in, you present this card, we're going to honor it, and nobody's going to bother you at the checkout window, other than maybe scheduling another appointment if you need it. Well, it was a little bit of a gamble, but it paid off for us, because when you're sick, even if it's the flu, guess what we're going to do? We're going to do a culture. We're going to make sure you really do have the flu, and we might even run a couple of, CBCs or something on you. And that is where we would end up billing you Blue Cross or something of that nature. But your primary health care visit was free. And whether you came to me or went to the hospital down the street, it was going to be the same outcome, except my office visit to you is free, and our neighbor down the street is going to charge you for it. So it was just a marketing, but it worked out very, very well. If you'd like to replicate it, I consider this all intellectual property. Okay. So those were the things with the rural health clinic. We advanced, when we first started the emergency room case management, we started it with the uninsured. And by 2010, we escalated it. We kind of got our feet underneath us and started moving forward. We moved it for case management of insured individuals as well. Because nobody should be using an emergency room inappropriately. It costs everybody. It costs it costs the federal government, it costs the state programs, it costs everybody. So we started working and educating our traditional insured population as well. And then we also offered ventilator care program in 2010. Now let me back up. In 2009, I talked a little bit about that niche market for Miller County Hospital. Our niche market was working with Grady and with Emory up in Atlanta. Those were our two partnering hospitals. I realized that, that they had a glut of patients in the Atlanta area who were really qualified for insurance if they had a place to put their head on a bed. They had patients in their emergency room in the wintertime that were homeless. And they were homeless, why? A lot of times because they had issues that Kay Brooks could deal with in behavioral health or developmental disabilities, but they were lost to a system. And that their ERs were flooded with those patients. And it wasn't just them. It was other individuals as well. Some of them, you know, I mean, you know, personally, I would say in some circumstances, they would be considered undesirable patients to a hospital, certainly to a community area. They were considered undesirable to my county. They actually revolted against me at one point in time. I can still see the headlines in the Miller County Liberal, residents on the loose. And that was when I remind the owner and editor every time I see him publicly of that particular headline. And that was when we partnered, I went to them and I said, look, I know you have patients up here that you are just, they're going back to the underpass, under 75. They've got health care problems. They need access to health insurance. They probably need, many of them need custodial care. Many of them probably are gunshot victims, bad drug deals that went bad, all other kinds of horrors that happen in our communities, but seem to happen, we hear a lot more about it up in the Atlanta just because of population. And I said, I think I have a solution for you. You don't want to throw them back out on the street where it's 19 degrees down. I got a nursing home right down here that has 30 empty beds. I'll be glad to help you out. You just call me. I'm going to send one of our nurses up here. We're going to screen them, see if they're appropriate. And we're willing to take them if you're willing to allow us access to them. So we developed a relationship over time with those two facilities, and they're still our biggest supporting hospitals, where we decompress their ER, we decompress their floor, and all we had to do was build a system within our hospital and within our long-term care facility to deal with those. Now, the catch to all of that is none of them had insurance. And so we ended up with about 20 patients within, I want to say 14 to 16 months, who are on trachs. And that was the niche market and the genesis of all of this. They had trachs, there were gunshot wounds, they had spinal cord injuries, they had all kinds of horrible things as a result, but they had been up at Grady or at Emory for months and months and months. They needed to be discharged, but nobody was willing to take them. No, they needed long-term care placement, they needed just long-term care. And no nursing home, which by the way, they're all for-profit, we are a not-for-profit long-term care facility, nobody wanted them, because who the heck is going to take, if you're, I have to put a filter on, if you're a for-profit nursing home, who's going to take a patient that has no health insurance and gamble on it? These patients needed to go through a disability process, which took oftentimes 18 months to 2 years. And in the meantime, Miller County Hospital had to pay for their lab, their x-rays. If they had to be hospitalized, re-hospitalized again, we had to take care of the 17 wounds, which were the average on these patients. and we had to fill all of their medications. So if you're kind of getting the broad picture of what we're building as an infrastructure between the pharmacy, the wound care program, I'm just going to go back a little bit, and then I'm going to hope I don't lose my place. All of these services were a genesis out of that very, very first niche market that we got. In order for me to be that partner for Grady and for Emory, I had to morph a rural hospital that wasn't even accustomed to putting an IV in patients. And so that's where all of these programs started from, and that was what got us to where we are today. By 2010, because we had so many trach patients and we had now respiratory care 24/7 in our nursing home, the state of Georgia called one day and said, you know, we'd really like to come on in and talk to you a little bit about what it is that you're doing. And because we noticed something unusual about you, your acuity level in your nursing home is really off the charts. We'd like to come in, but your quality measures are very good. We'd like to talk to you a little bit about it. By the end of that meeting, they asked me if I would consider introducing a pilot program to the state of Georgia, and that was for long-term care ventilator patients. It was the first of its kind. We opened it in 2010, and we opened it with 4 beds. We opened it with 4 beds on a wing that had 14 beds on it, but we started it with 4 beds, and we started it right at the beginning of 2010, right around July of 2010, fiscal year 2010. And I'm going to tell you, when I immediately said, yes, I would do it, my director of long-term care and my chief nursing officer thought I was off my rocker. They thought this was like, no way, this is too much. Well, here we are, almost 7 years later, and we right now have 60 of these patients in our home, and we are under construction of another 50-bed unit to handle them. So in 2000, but it started with those trach patients and that original partnership. So, you know, and I say to people all the time, you know, you cannot take a program and just think you can plunk it someplace else. As a matter of fact, I get angry about that, to be real truthful. You know, Walmart does really, really well in Bainbridge, but I would venture to say that on Fifth Avenue of New York, it just wouldn't survive. And so you've got to, in these rural communities, you've got to figure out what is going to work for you and work for your organization. And part of that is just developing a business plan and taking a couple of chances and going after it. But we found some really, really good partners in all of this. By 2011, now remember the $3.5 million that was called due in 2009, it took me until 2011 to get the USDA to belly up to the bar and say, yes, we will allow you $3.5 million to refinance your debt. But here's how it works, Ms. Rao. You're not just getting $3.5 million. If that's what you want to borrow, then we also, and this was part of the Barack Obama's, the President Obama's plan, is we also want you to be now an economic stimulus program. If we're going to let you borrow $3.5 million for consolidation or refinancing of debt, you have to borrow another like amount of money and do something with it to stimulate your local economy. Well, that for me was a no-brainer. I knew exactly what I could do with the rest of the money. So we got all the gyrations were done and we got the loan. We repaid the banker. He was very happy, needless to say. In 2011, we also started then the 340B pharmaceutical program, and I'll talk a little bit more about what we did with the remainder of the money. As a matter of fact, I'll show you some photos of it. But we also started in 2011 the 340B pharmaceutical assistance program. Now, I'm going to tell you, this is a program that is under attack at the federal level, but it is critical for rural hospitals and some other PPS hospitals to be able to utilize these funds. Because what these funds, and people talk about it as pharmaceutical or drug program, low-cost drug program, this program has allowed me to use those low-cost medications that we basically buy from the federal government in an indirect manner, at pennies on a dollar, truthfully. And it allows me to fill for the 54-year-old woman who comes into our hospital who has no chance of getting disability. She's classic African-American. She's typically overweight. She's diabetic. She doesn't have access to transportation. She doesn't have health insurance, and so she doesn't have money. She doesn't have any subsidies, absolutely nothing. This 340B allows me, or the entire program allows me, to see her in our clinic. She can come in there 10 times a day, I don't care, and this is how our indigent care program works. Once you qualify for financial assistance at our hospital, and this is what our case managers do, you qualify for financial assistance, we give you a card that says that you qualify for financial assistance at Miller County Hospital, free access to either of our 2 rural health clinics. You can go in there 5-10 times a day. I don't care. I don't care how many times people come into my clinic and I give them free care in our clinic. All I ask for is that you allow us to manage your care, you allow us to get you a medication assistance, and you stay the heck out of my emergency room. Let us keep you healthy. Now you can see all of this has been going on since really 2010, when we upped the federal poverty level and we put in an LPN in our ER years ago. This is all part of the genesis. The 340B program then allows me to give them not just their medication, but allows me to give her a glucometer, her strips, which are, if any of you are diabetic, you know how expensive those darn things are. Allows me to give her her strips. If she's asthmatic, I give her a nebulizer. I can give her syringes. All of this, that's what that program allows me to do. So if you ever hear anyone talk about it, it's a good program, but there may be, again, bad actors using the program. We use it the way the program is designed to be used. And at the end of the day, it's helped us tremendously. So we also, there's Miss Kay Brooks, and I told her I was going to call her out. I know she probably wants to crawl under the table, but Kay and I don't know if she found me or I found her right around 2010, but we started working together and talking to one another around 2010, and then in 2011, I said, you know, I have this empty building. It's not on our campus, but it's not far away. How would you like to just bring Albany Area Community Service Board right over to Miller County? And so she did, despite the fact that the building was in terrible shape. She and her staff moved in there. And that was the beginning of another partnership with behavioral health developmental disabilities. You know, we heard a lot about mental health today and developmental disabilities, but I absolutely believe that it is part now and needs to be part of the everyday discussion. It is part of primary care. We can all bury our heads, you know, in the sand and act as though it happens someplace else, and it really isn't affecting us, but it absolutely is, and we're hearing more and more and more about it. But healthcare workers have been aware in the emergency room for a long time. The pushback from us in Miller County has been our primary care physicians willing to deal with it and identify it. But bringing Albany Area Community Service Board adjacent to our campus was critical to start a dialogue in 2011. By 2012, the remainder of that money that came from the USDA, we started doing some additional renovations. And we actually spent $5.6 million. So we used, by this point in time, oh my God, we actually had some money in the bank, and Miller County Hospital had $1 million to fund, all on its own, some of the renovation projects. So we went from losing millions of dollars, not having $100,000 in the bank when I first came here, to by 2011 and 12 actually having cash in the bank. 2013, We knew we were going to renovate Miller Nursing Home, and that was going to be part of the USDA package that we had. And also, in February of 2013, Calhoun Hospital closed in Arlington, Georgia, not 13 miles away from Miller County, 13 to 15 miles away from Miller County. Another rural hospital closed, it was Calhoun. When that hospital closed, along with it was going to be a nursing home and also a rural health clinic. If that rural health clinic closed, there would be really no health care in that community. Now, you saw the statistics in Calhoun County. They are worse than Miller County for poverty, education, all of those kinds of things. We looked at them probably about 40 minutes ago now. It is not a book of business that a hospital CEO would ever in their right mind say, oh, yeah, I'd love to open up a primary care clinic or maintain a primary care clinic in that. Financially, it doesn't make any sense. But I felt very strongly back then, we cannot just allow another rural hospital to close and leave individuals without any access to primary care. So we came in with a plan to secure the rural health clinic, and we did open that. We still maintain it today. And we also acquired their 60-bed skilled nursing facility at the same time in February of 2013. With that, again, we rolled out the 340B program to I think it's the fourth poorest county in the state of Georgia. We rolled out 340B. We rolled out care management over there, and we began renovation of the Miller Nursing Home. That's 60 beds, which, by the way, that nursing home, 60 beds, and it had 20 empty beds when I acquired it. Still more of that math, 1 bed for every 8th versus 1 bed for every 14, 20 empty beds, empty in there. We used it as a staging area as we did our renovations in our nursing home. And part of that project is we brought oxygen and suctioning up to an additional 40 beds. Ultimately, we have right now 75 beds that if you were to look at them, you would think you were looking at an ICU. Some people in this room have seen that facility, and it looks as sophisticated as an intensive care unit, and that's our nursing home. We plan to then expand the ventilator program over to a dialysis program, and this is the reason why. When we did the deal with the state of Georgia and said, we're willing to do a ventilator program, the state also agreed to just put some regional facilities in place and not allow everybody to go out there and build programs. We also obviously want to help out the state of Georgia, right? We don't want these patients sitting in Emory, Grady, Archbald, Southeast Alabama, or any place else for 18 months just because they can't find placement. So we want to help out the state of Georgia, keep our Georgians patronized in our home, because guess what was happening before we opened our program? These patients many of them were being shipped out of Georgia, and at this point, only a ventilator program. They were being shipped to Tennessee, to Maryland, to Illinois, all over the place. And so our state tax dollars, because they were now Medicaid, state tax dollars was being sent out of the state to these other states to care for them. So our promise back to the state is we're going to focus on Georgians, and we're going to keep that pool of money within the state of Georgia. Problem is, regionally, I am at the low end of the state. I am the low-hanging fruit, but for the wrong reason. If my partner hospitals or tertiary care hospitals that I commit to help out are in Georgia, and I'm at the southern end, guess where all these other hospitals were? They're at the northern end. Atlanta, Columbus, Savannah, Athens, okay? And guess what happened? 4 other homes opened up that could do ventilators. Doesn't it make sense then? They now become the barrier between me and Grady, me and Emory, me and Savannah. So the next notch for me was, okay, we got to belly up to the bar one more time. There is another niche. I can tell you, Archbald operates dialysis facilities. I would get phone calls from CEOs, care managers, and sometimes CEOs saying, Ms. Rao, won't you please consider accepting our patient? And the patients were trach dialysis or vent dialysis. Now, Archbold is right around the corner, and I would ask them and go to them. I tried it about 3 different times and said, look, I'm willing to accept the patients, I'm willing to transfer them, I'm willing to send my respiratory therapist with them. Will you agree to dialyze them? And every time I asked that question, I was told no, they were not willing to do it. So there was one other way to skin this cat, isn't there? If there's a need, it's go ahead and open up your own daggum facility, and that's what we did. So that was then the genesis, the need, because there was a need for these patients to be placed. Nobody else would take them. And we are still today the only center short of Illinois or New York. We expanded our relationship with Swig Creek and started doing marketplace enrollment. Again, why? So we'd have some more patients. This was how stupid I was back then. I thought, oh yeah, great, let's enroll these patients. I'll have Blue Cross or whatever the heck. I've got a great Blue Cross contract. Well, except that their deductibles were $5,000 and $10,000, so that didn't exactly work out to my benefit, but it was a good thing to do. And we also partnered with, we started partnering with the Cancer Coalition of South Georgia, and we contracted with them for some colorectal cancer navigation. I believe cancer screening is just basic primary care. And then in 2014, we started doing things like escalating all of this. And let's screen patients for earned benefits, SNAP, housing, et cetera. Let's get people aligned to the services that are out there that the taxpayers think we're already funding, but let's get them to the people that we know really need them. We did a $2.5 million renovation project in our hospital. Our facility was built in 1957, and as I often say to people, that is the same year that I was born. Do I or do I not look like I need some care every now and again at this age? Well, that's my hospital. So it needed some support, so we did the second generator then. We put a brand new roof on the system that was energy efficient. We updated, oh my God, we still had like fuses in that hospital. Now, can you imagine, 1957, do you really think an MRI was available back then, or a CAT scan in 1957? Dr. Story probably knows this answer. CAT scan might have been in its infancy, but imagine the power that technology requires. And we're still using an electric system that's built in 1957. Cooling and air quality, and we also opened up a new operating room, and we constructed our dialysis facility. By 2015, the dialysis facility had been built in 2014. By 2015, we brought dialysis inside our hospital and inside of our nursing home, and that's where we completed then the 74 beds for our long-term care vent system. We also added digital mammography for our cancer screening program, and then in 2016, we added 4 additional long-term care beds. So we took our license up to 107 beds at that point in time. And we also did, a 6,000 square foot pharmacy expansion to accommodate the growth, and we formed Deep South Accountable Care Organization with several other partners at that point in time. Again, expanding on what we had already done. This year, we are right now in the process of constructing a $23,000 square foot addition to our long-term care facility, 8,500 square foot medical storage facility, redesign of our emergency room, part of that with funding from the state, a demonstration project where we can isolate mental health and infectious diseases, and this project will add 100 additional jobs. So we've got mental health expansion going on as well with Kay and her people. I'm trying to move along quickly. I bet you I'm running out of time. So let me just tell you about some of the things. You know, people talk about physician recruitment and retention. Physicians are no longer, indentured servants. They want a daggum life. At the end of the day, they want to go home, just like I want to go home. And so recruitment in rural areas is very, very difficult. That's part of the reason why we staff with mid-levels. Those mid-levels give the physicians the lifestyle that they really want to have. They want to be able to go home. Our mid-levels respond to concerns in our nursing home and onto our floor after 5 p.m. at night, as well as on weekends. The coordination of care, some of the things that we do is chronic care management. We right now only have 29 patients enrolled in that. There's a slow program. People feel it's very intrusive, but it is a good program. We'll help them with financial assistance, medication management, et cetera. Transitional care management is something else that is just big with the federal government, and it's post-hospitalization care follow-up, which, believe it or not, we just really didn't do. I mean, so you get discharged from our hospital. Ask me how many times somebody would call you and say, hey, Betty Jo, how you feeling today? Did you take your medicines? Can you follow your instructions? Shame on me that it wasn't going on, but I'm telling you, it wasn't going on like it should have been. And then annual wellness visits. We've done 587. Now, I've been in Georgia 20 years, okay, 20 years. And I tell my staff all the time, in my 20 years, and I have worked for a couple of hospitals and a host of physicians. You know how many times I am embarrassed to say this, but it's classic. In those 20 years, I've only been asked once, Miss Rao, have you had your mammogram? Miss Rao, how about your colonoscopy? You're over the age of 50? You had a pelvic exam lately? Primary care has got to change, and that's really what we are trying to do with our transitional care and our annual wellness visits. So I just drove by Kay Brooks' little building over here, and let me just say, this is not my program. This is Kay Brooks and Albany Area Community Service Board. All I did was try and broker some people and say, look, we had a hospital that closed. Can we do something in this area to create some jobs and at the same time meet a medical need? And that's where she and her people bellied up to the bar, and very, very quickly. So I was very proud of that sign there, Kay, when I saw it about a month ago. So just in terms of us talking about behavioral health, this is just in a 6-month program. We've had 25 1013s come through our emergency room. 11 of them are children. Now, I don't know if 25 is a lot, but I think it is in a county of 5,000 people. And for a 7-year-old child, you know, I mean, this is the thing that when I think about this, why we're not all angry is beyond me. There is something so wrong. When I was 7 years old, I was out playing hopscotch. I was playing with my sisters. I was doing all kinds of things. I had a wonderful, wonderful childhood. And to think that a 7-year-old child would think about killing themselves, I mean, that is just an indictment as far as I'm concerned. So the average time in our ER before transfer is 10 hours, but it can go way, way, way up there. We've had them in that ER before transfer up to 70 hours. For schizophrenia, suicidal ideation. And this one patient that was there, was an elderly man, was in there for 70 hours. We tried 17 facilities before we were ever able to find placement. These are not the patients that our hospital is equipped to deal with. We simply are not. So Kay gave us, several months ago, she talked to our medical staff, and she gave us a simple screening tool for mental health that our primary care physicians, and again, think about this, how this is all building and coming together. She gave us a simple screening tool. Our doctors who never even wanted to admit that there was a mental health problem, since that point in time, have made 48 referrals to her program. They've screened 1,328 patients with that referral and found 48. The program that slide that, okay, there it is. The program that you saw right here, this is the residential treatment program called Touchstone. And it's an integrated program. She's got 28 beds. I think she opened it in May of this year, Kay, somewhere around there. And as of May, out of the 28 beds, she had 24 filled. She's now got 52 full-time employees talking about a rural hospital and what a rural hospital can do in terms of economic development. So now Miller County, and I'll wrap this up, we currently have 500 employees. 500 employees on our payroll, full-time employees. Our annual revenue is now $60 million. May not be a lot. For me, it's a lot, because guess what? That is volume generated. I haven't, in all of my years, in my 8 years there, we've never raised our rates, not one penny. And why? Because all I would be doing is driving it down to people who can't afford to pay it anyway. Our insurance companies aren't going to pay it. So what's the point? So this is all annual revenue based on volume alone. Our current salaries are $20 million in salaries, $24 million with benefits. Workforce development is a huge issue, so we offer scholarships to RNs, LPNs, respiratory therapists, CNAs, pharmacists, physicians, anything and everything to develop our own workforce. Our average employee in Southwest Georgia has a salary of $45,000 a year. That's good living. We offer free health care to all of our employees and their immediate families, free access, free health care, no charge. All you have to do is use us. That includes pharmaceuticals. We also went out and offered a stipend to Andrew College, and they opened up, which is in Cuthbert, Georgia, they opened up a nursing program, and they've got 34 students coming in. We did this last year. They've got 34 nursing students coming in August 15th. And then we're a training program for University of Georgia, et cetera. Here's the thing. Look at these, if you look at our salary expenses going from $9.6 million just salary to $19.6 million since 2012, that's a ton of jobs. But look at the cost of our benefits. It has gone down since that point in time. And why? Because I'm keeping my employees healthier. So there's your demonstration project. We provide just a bunch of uncompensated care, but you can see in 2012, $3.4 million down to $2.5 million. Our uncompensated care is only 4.5% of our revenue. I bet you there's not another hospital within 200 miles of us, I'd be willing to make that bet, that can make that claim. And why? Because it's the annual wellness visits, the care management, the pharmaceutical assistance, all of those things. Now, here's some of those cards that I'm going to give you if you want to.
Okay.
Yeah. So you can see we do them for all of the businesses. These are just examples of some of them. This is our nursing home before we did the renovation project. Wouldn't you love to live in that? And this is the renovation project. Some more of the renovation that went on. We took that nursing home down to the studs, and then this is a classic nursing home room. Oh, this is our electrical system. Oh my God. And here it is today. So that's how we spent all of that money. There's one of the generators that we put in. This is a bone scan DEXA machine. This is that digital mammography unit. Here is our receiving and storage area that is like so darn tight. And this is our pharmacist with all those pharmacists working in there like a bunch of little rats. This is now the new pharmacy, part of it. And look, they look happy, don't they? This is our emergency room renovation project that you see right here, and some other construction that's going on. This is a building that Kay Brooks is in today that I told her she had to get out because I'm about to demolish it. But I'm buying her a new building, okay. And we are accredited. Anyway, okay, I'm sorry that I was long. I don't know how long I was, but listen, don't ever ask me to come and speak for a definitive amount of time because I cannot do it. All right. I know there's no questions. You may. I would be glad to give it to you, Mr. Jackson. Thank you.
I think we'll probably all have questions because that was intriguing and also inspiring. But we're running a little behind, so we're going to go with our next presenters. but I hope you will be around for a while because I think we will probably have some questions. The next two presenters we've got are from Archibald. We've got Kelly Vaughn and Amy Griffin. They're going to talk about developmental disabilities, behavioral health in the post-Southwestern era. And also they're going to talk about, or Amy's going to talk about collaborative efforts among healthcare providers to make sure that we have access to critical health care in Southwest Georgia. So let's give them a warm welcome.
Make sure I have this. Okay. Good afternoon. I don't have a PowerPoint, so I'm good. Yeah, I'll spare you the PowerPoint. Good afternoon. I am Kelly Vaughn. I am the Director of the Emergency Department and Trauma Service here at Archibald in Thomasville, Georgia. I have been an ER nurse for 20 years this year and had about a 10-year stint as the Trauma Program Manager for Archibald, but have had emergency background my entire nursing career. So I've been asked to address behavioral health issues related to hospitals, and I appreciate your time and listening to what we have to say. I do want to recognize the efforts of our regional behavioral health office. Jennifer Dunn does a great job, and Phil Chastain, who is over our crisis center. We have each other's cell numbers. We talk about issues real time, and I greatly appreciate those efforts because a lot of times it's very easy to address the issues real time than it is to talk about them 2 weeks later. However, I think we need to look at the challenge, and the challenge, in my opinion, is to provide these patients with the services they need in an environment that they deserve in our local area. I mean, I think ultimately, bottom line, we always have to bring it back to the patient. Behavioral health patients that present to our emergency departments or our hospitals in our region, a lot of times they're in crisis and they're in their worst state. And when that happens, these patients require a lot of work. They require a lot of work from our providers. They require a lot of work from our nursing staff. Security gets involved. EMS is a lot of times stays. Our sheriff's office or our police officers a lot of times are there with us. And they can be challenging. It is a community effort for us in our emergency department, and it takes our community, and I appreciate the efforts they have. Just to give you some idea, our average length of stay for the patients in our department are about 11 hours. So when you have someone that presents with a behavioral health issue or an addiction issue, our average length of stay is 11 hours. So we have to kind of think through how we're going to best serve this patient in our emergency department for 11 hours. That's kind of what I preach to our providers of how can we best serve this patient. Just understand that they could possibly be here average 11 hours. So what are we going to do? How are we going to best proactively treat this patient? One thing that I will say, and Jennifer did acknowledge this, is physical space is something we're lacking here. So patients, they have their medical screening exam by the ER providers, and then they need placement. And a lot of times the crisis centers are full, local areas may be full, and in those situations, it's going to be a challenge. It's a challenge finding them a place to go. When you think about behavioral health and you think about patients with addiction issues, the best treatment that research shows is that these families need to be involved. And a lot of times when you're trying to find placement for these patients, you may have to go to Atlanta or Savannah, or you're sending them to Columbus. And these patients get the treatment, but a lot of times the families don't get what they need to help these patients after the treatment is finished. So I think that's something we need to look at, is some sort of physical space in our area. How can we increase that? The other, lack of pay source, and the commissioner talked about that. A lot of these patients don't have a pay source, and so sometimes that does prolong finding placement for them. So some sort of resource availability to get them a pay source so we can get them where they need to go. The second thing that I would like to address are the patients that need psychiatric care in an inpatient setting, but they have medical complications. These patients are very difficult to place. just an example, patients with respiratory problems, maybe they have chronic lung disease, maybe they're severe asthmatic, they require medical treatment. Our ER providers will tell you, from a medical perspective, when I evaluate this patient, I look, does he need to be admitted to our inpatient hospital or does he not? If the answer is no, they don't require an inpatient admission for their medical condition, let's focus on the psych part of that. Well, a lot of times the psychiatric facilities will then turn them down because they don't have the ability to care for the medical part of this patient. So that is something that I'm not sure whether reviewing what the credentials are or how to better resource the medical piece of the psychiatric facility so that these patients that are more complicated medically can get the psychiatric care they deserve while being treated for their chronic medical condition. I'll give you an example. We had a patient who had a hernia that was not operable. It was fine. There was nothing wrong with it. With him, he did not need an operation for his hernia, yet no psych facility would take him. We had the surgeon come down, do a surgical consult, said, no, there's nothing that needs to be done for this. This patient is fine. Sent that consult out to all the psych facilities, and they still wouldn't take him. So these are things that we just have to figure out. How can we better support the psychiatric facilities with medical providers so that when these patients do need to go somewhere for inpatient psych treatment, they can also get the medical care they deserve. The last thing I'm going to bring up is just lack of resources that are available for patients with autism in our area. That is something that we see quite a bit in our emergency department, and I do appreciate, I know there's been some increased funding from the Georgia state level this year, and I greatly appreciate that effort that's being put forth. Some things that I have looked at just related to our area. The FSU has a Center for Autism and Related Disabilities that's funded by the Florida legislature, and it serves 18 counties in the Florida Panhandle. It may be worth taking a look. They have satellite offices in several areas, and they use those satellite offices so that families can go locally to provide care for these patients with autism. And I don't know if that's something we can set up or even model after, or look at how they're doing this and maybe look at this for Georgia and how we can have satellite offices or regional areas so that we have the Marcus Autism Center. I know that. They're wonderful. They're in Atlanta, but they're 5 hours away. And if a lot of times when you have a child that you're trying to drive 5 hours to Atlanta, that's hard for just a child, a 5-year-old anyway. But when you have developmental delays on top of that, you're talking an even more complicated trip. So if we could look at some sort of regional satellite offices, and then maybe advance even down the line, do some sort of telemedicine or some sort of satellite so that the Marcus Autism Center could reach out and have access locally to these kids. I think that's something that we need to consider. I appreciate your time, and that's really all I was going to say. They're the three things. It's just like a physical space, the patients with chronic medical conditions that truly need psychiatric care. They don't need inpatient medical admission, but they need psychiatric admission. They just can't go there because of their chronic medical condition. And then the lack of resources for patients with autism. Any questions? Yes.
Thank you for coming. Does it appear to you that some of our psychiatric facilities look for ways not to accept patients with additional, let's say, problems? For example, with a patient that has psychiatric difficulties that might also be pregnant, do you find that it is more difficult to place some of these, or with open wounds, or
Yes.
Yes.
That is all included in that chronic medical conditions, yes. They can be.
So it appears to you that some of these facilities are looking for reasons not to take patients.
I
Is that
don't
what
know
I'm
that
hearing?
I don't know that that they're looking for reasons not to. I think that we need to just back up and reevaluate what the psych facilities have as far as medical care they can provide and whether they feel comfortable managing those types of patients. Do we need increased education? Do we need more, does the medical staff, does there need to be an increased medical staff in that area? I'm not really sure.
But with the example of the patient that had the hernia that did not have the hernia, that you've got a surgeon that looks at him and provides information that, no, this guy does not need surgery, yet it takes 70 hours to place him in a facility because of this problem that wasn't a problem that they're not taking, even though you've got a sheet of paper signed by a surgeon, this guy does not need surgery. It appears to me that some of the facilities are looking for reasons not to accept patients.
I'm not going to answer for them. I know that it's, I know that from my perspective, it's a challenge. And so I'm one of those, I know one of the representatives said earlier, bring solutions or possible solutions, and I am driven in that way. So I would propose to back up and look at the facilities and look at the medical care that's provided or the types of providers that have access or provide care in those areas, and then look at the nursing education, because there are nurses that take care of these patients too. And so I know they have great psychiatric education, but do we need to look at a more advanced facility that can provide medical surgical type care as well as psychiatric care?
So for the crisis centers, the behavioral health crisis centers, they're not hospitals. So they don't have a hospital pharmacy. They're licensed as a residential setting. They can't give oxygen. They can only do breathing treatments. There's a lot of things that they're not able to do medically because they're not a hospital. And I think that what we try to do, though, to answer your question, is, and Kelly's worked really well locally with us on this, is do doc to doc. So the two doctors get on the phone and talk to each other so they can really get a clear picture on what is exactly happening.
I have a question.
Sure.
Can you just help me figure out how to deal with a situation in my home county of Taylor County? We don't have a hospital there.
Right.
But we have really good EMTs. Our EMA director, his team does an excellent job of sustaining people when they're sick to get them to the nearest hospital. In most cases, it's like 35, 40 miles away. Well, oftentimes they may arrive at emergency room and for some apparent reason, they can't leave the patient at that time. They have to stay there with them. There's been a few occasions where they had to stay in the emergency room hallway in some cases with the patient. They could not leave. And so while they are away from the county, there may be another incident or another situation that may occur, and we don't have the ambulance present or the staff present to assist in that situation. So, and what I've been told is oftentimes they arrive at these emergency rooms and they can't leave when they really need to. So can you kind of help me understand why that would be the case?
I think you're talking mainly about EMS boarding of patients. And so a lot of times in our emergency departments, what happens is we're overloaded. We have multiple EMS coming from different areas. And a lot of times you're trying to, as the charge nurse, which was probably who they're dealing with, you're trying to determine what patients can come out of a room so that this patient who's most acute, where do they need to go, and how do I need to best place them. EMS, and I don't want to speak for them either, but I do work with them regularly, they have to hand off the patient. And sometimes the nurses, they don't want the patient handed off until they can figure out where the best place is for that patient. And so it sometimes does take a little bit of time. We struggle with that. We don't struggle with that near to the effect that like Atlanta would or a lot of the larger facilities, but it does happen. There may be 15, 20 minutes where EMS is standing right there waiting on us to get a patient out or move a patient, clean the room, get a spot ready, get a new stretcher, put it in the room, transfer the patient over, get report, and let them leave. I think from an ER perspective, our ultimate goal is to take over the patient and then provide the best care that we can. But there are times when that may be delayed. I apologize, but it is a national issue.
Okay, thank you.
Any other question?
Good afternoon. I'm Amy Griffin, the Chief Nursing Officer at Archbold Memorial Hospital in Thomasville. I've been a nurse for about 28 years and been with the Archbold system for about 26. Been in my current role as a Chief Nursing Officer for about 7 years. So I do appreciate the opportunity, appreciate you coming to South Georgia and the opportunity to provide you with some information about our system, as well as some challenges in rural health access. We're a 540-bed healthcare system, which are 4 hospitals, 2 which are acute care hospitals in Thomasville, as well as Grady County, and then 2 critical access hospitals in Brooks County and Mitchell County. We have 3 nursing homes. We employ more than 2,500 staff, 200 physicians, and over 900 licensed nurses in our system. Our system approach allows for standardization of processes and consolidation of services. I think that without our system approach, many of our critical access hospitals would not have the ability that they have in terms of infrastructure, information technology. We consolidate our services in terms of how we profile medications in our pharmacy, our linen and laundry distribution, as well as our IT management team. So there's a lot of benefits from the system approach. I think that we, from the system, we gain a presence, but also we gain expertise, resources, staffing, and stability to all of our hospitals throughout our system. I think Robin mentioned earlier that rural hospitals are experts in care transition and coordination of care. Oftentimes, these hospitals stabilize patients, they do the diagnostic testing, and then coordinate care back and forth between specialty services. So much needed access for our patients in the community. I do want to mention, we've heard today that there are challenges with healthcare workers and how we are able to get qualified medical professionals in our organization. Being a nurse, I want to focus a little bit on the nursing shortage. In Georgia, there are too few nurses, and the problem is going to get worse. Georgia Health News has reported that 80,000 students are turned away from nursing schools every year due to nursing schools not having adequate faculty. Oftentimes, the faculty in these organizations are the highest level trained, doctorate, master's prepared, and they're oftentimes the lowest salary. So to attract the faculty that are needed, we need to look at how that salary is structured. As the economy's gotten better, many nurses have exited the workforce or gone part-time or left the profession altogether. The United States has 874 RNs per 100,000 people. The problem is this is not distributed evenly. In the state of Georgia, we have 665 RNs per 100,000 people. So hospitals and states where the concentration is less are going to have more difficulty filling those positions. The demands for nurses in Georgia in 2012 was just over 77,000. In 2025, the demand will be close to 102,000. The Georgia Board of Nursing recently talked to us in our CNO Council in Georgia, which was with our Vizient group, and stated that for the nurses that graduate this year, in 3 years, close to 40% of those nurses will have left the profession. Ma'am?
As a nurse with advanced degrees, why are they leaving? And as a former nursing faculty member, I know the answer, but
Yes.
why?
Oftentimes, the nurses leave because I think one thing that should happen is that there should be some shadowing process for nurses that are entering the nursing profession. Oftentimes, our nurses enter and they don't really know what they signed up for. And when they realize the workload, the burden that it is, taking care and putting yourself out there to care for others every single day is a huge commitment. And it is something that I'm obviously very passionate about, but oftentimes people enter the profession because they think it's a stable career and not really for the reason that they need to be in the profession.
I think you hit on it. I chair the Health and Human Services Committee in the Georgia House. And the deans of the School of Nurses are on one wave. They think they're turning out perfect nurses. And I'm hearing from the nursing CEOs in the hospital that we are turning out nurses,
That's
that
right.
RNs, that cannot function on a basic med-surg floor, not specialty, but basic med-surg,
That's correct.
you know, when they get out of nursing school. In the big hospitals, they're having to start year-long mentoring programs, but small hospitals don't have the time or the expertise to do that, and it's one of our major problems, and it's why they do leave.
Exactly.
So I'm glad to hear you.
And along the training, we have, technology's wonderful, and we've moved to simulation labs. And oftentimes, the clinical space needed for the colleges and universities, particularly in our area, we serve 4, 5, sometimes 6, and you don't have the clinical space for them. So that's another reason that some of our nurses are coming out, and they don't have the clinical expertise that's needed. Also, we've moved away from a licensed practical nurse in the acute care setting. I think as the demands for quality demands have gotten higher, the demands on nurses are more, we've had to go to a higher level degree. So what's happened is in areas where licensed practical nurses, it's great for them to be in that setting. Physician office practices, dialysis facilities, long-term care, those people are not going into the LPN programs anymore, so that has limited also our ability to staff those areas as well. Our current vacancy rate is 11.9%. In our Vizient networking group in the state of Georgia, it ranges from 6 to 20%. As you know, that with a vacancy rate that high, it can lead to bed closure, increased workload on our nursing staff, and an increased nurse-to-patient ratio, which oftentimes, facilitates people leaving the profession. The cost of nursing turnover is currently stated about $64,000 per nurse, and the orientation period for a new nurse, depending on where they will go to work, is anywhere from 3 to 6 months, sometimes up to 8 months if they're in the operating room, dialysis facilities, emergency departments. Recruiting in rural areas is often difficult due to lifestyle, spouse jobs, the economy. Limited continuing education opportunities, as well as professional isolation. I will tell you that in many of our smaller facilities, our employees are a part of that community, and oftentimes they have suffered the same economic situations that are in that economy, and they don't have the opportunity to advance their career or advance their degree. I will tell you that in our system since 1956, we are very fortunate to have a well-funded scholarship program as well as a tuition reimbursement program. We currently have about 50 students on our scholarship program, totaling over $375,000, and about 50 employees on our tuition reimbursement program, totaling greater than $280,000. And the payback, the work commitment for that's about a 2 to 3 year commitment for that program. We also provide tuition supports provided by the hospital. It serves as a profound recruitment and retention tool and demonstrates a deep commitment of the hospital to the people in these communities. I can tell you story after story of individuals who started out in our hospital as van drivers who are now mid-level providers, and that would not have been possible without the financial commitment of the organization. Our organization supports local nursing schools with financial contributions as well as clinical space for training. Several of our staff members serve on advisory boards to colleges and universities, and we work in collaborative partnership to meet the needs of both the health system as well as the college and university. Some examples that we have had to constantly meet the needs and accommodate our working staff. We've had to waive tuition till the end of the semester for some of our staff, and we've also had to look at opening up weekend off-hour clinical space for our colleges and universities to accommodate them. I would like to take a minute just to talk a little bit about our retention strategies. We have a professional practice model for our nursing staff that, depending on the level of their commitment throughout the year and what they've achieved, they're given a bonus in December up to $2,000, $3,000, $5,000, depending on what they've accomplished throughout the year. We have recruiting incentives, sign-on bonuses for new nurses all the way up to experienced nurses up to $10,000 for a 2-year work commitment. We also have a finder's fee. If a registered nurse can get a nurse buddy to come on board with us, we'll pay them $3,000. We pay relocation fees for any nurse moving into our area. Like I mentioned, we have tuition reimbursement up to 100%. Our RN pay rate increases, the demand and the pay, as you saw from Robin, over the last several years is quite demanding to be competitive. Over the last 2 years, we've increased our RN pay and another schedule for this upcoming year. For every $1 increase in our system, it costs us $1.5 million. And in order for us to be competitive in South Georgia, oftentimes our nurses come from Tallahassee, Jacksonville, or the Atlanta area. With seasoned nurses, we find ourselves anywhere from $3 to $5 behind per hour. So this year, we're considering retention bonuses for our more experienced staff. We have a high dollar PRN rate that is competitive with our agency staffing. As more and more hospitals have vacancy, agency contract staff is coming back into hospitals, so your seasoned nurses are leaving to become contract nurses. We also are bringing back the Baylor plan, where a nurse can work 56 hours in a 2-week period and be paid for 80 hours. We've had to increase our marketing and advertising efforts. We are contracting with local firms to place nurses permanently in our organizations. We've increased our social media awareness, career fairs. We're actually contracting with new graduate nurses before they even graduate. And lastly, we have done something this year that we are entertaining the idea of international recruiting firms. So I just ask you that as we move forward in rural health access, that we also look at how we can recruit and retain qualified medical professionals to support. Otherwise, we have hospitals with bed closure, and our communities suffer from that. Does anybody have any questions?
I don't know about many of y'all, but I'm sure these chairs seem like a good idea when they were purchased. For us oversized individuals, they're just a little bit of a challenge. Next, we're glad to have with us a couple of individuals to kind of share with us a little bit about the impact of the opioid crisis and many other mental health crises and everything else in local communities. And I'm looking around, and I don't see them in here yet. Oh, okay. So we've got our local sheriff, Mr. Carlton Powell, and our from Thomas County here, and then the chief of the Thomasville Police Department is Chief Roy Rich. So if you gentlemen would come on down and tell us a little bit about what y'all are dealing with, and then we will ask at the end for our presenters that have presented and are still here, if y'all would stay around for a little bit in case there's some other questions that some of our council members have that they would like to ask. So gentlemen, thank y'all for being here. Thank you for what you do every day.
You want to go first, Chief Rich? Okay. Well, we have heard a lot of things today. Some of them I wanted to had to do with mental health, but that's just me. By the way, I hope you will convey to the speaker what our concerns are. Representative Carter. Let me say that I'm going to be up here talking mainly to the people who are in Atlanta that's appointed, and that's our state representatives, and I see some of the local ones here, and I've seen a few of the people that are from other parts of the state. I think that I'm here today to say that when you get down to what our problems are in the state, quite often we talk about everything about what the problem is. We talk about a lot of issues here. You representatives and senators are who I'm speaking to today. When we started closing Southwestern State Hospital and other facilities around the state, we all knew that it was not the will of the people of Georgia in particular, but it was a mandate that had been signed. and approved, and consequently, there was people in positions of power who felt like this was the best way to get out from under a suit that we was under. And so we did the closing of the facilities. Ever since then, we have had a continuous problem of trying to find a place to put these people. And being the sheriff, they tasked the sheriffs of this state with the responsibility of getting these people to the facilities. Needless to say, they do not count the cost to the individual counties. I'm just one of many, and I'm probably a little bit better shape than some, that has the responsibility of getting these people to the hospital. Now, you probably would say, well, that's not such a big job. In 2013, we made 998 trips to facilities. We had Columbus, or Macon, or Savannah. Columbus is 150 miles, Macon's 150 miles, and Savannah's 190 miles. One day, a couple of weeks ago, we made 3 trips to Savannah in one day. One car left, come back, another car left, come back. Because we don't have the option of saying, well, let's hold on to these people for a day or so. When they call and say they've got to go, we have about a few minutes to get them on the road. And if you don't, when you get there, you might find out they've given your bed up. Now, that don't sound bad to you people that don't have to do it. But that's a big cost to the people of this state and these counties. We figured out it cost us about $480,000 for 1 year. We're on target, and now we've had over 400 trips so far this year. I'm just saying to you that we have some facilities, and I know these state representatives and the senator are not here because this is something they wanted. They don't. I'm here to tell you this is something that's been mandated and they had to do. But the local people are picking up the tab, and the local people are picking up the lion's share of the cost to do this. This may not be the subject that people told me to speak about, but I'm going to speak about it because I think people need to know. The public needs to know. If you hadn't had some of this happen in your family, consider yourself very lucky. Most of the people sitting in this room, and certainly some of you, are in far better shape when some of your family has to be, because y'all know the rules and know some of the people to touch base with. I'm talking about the great bourgeoisie out there who does not know all the details of who to contact. They don't know what to do. I will tell you, I had a personal experience within my family of someone that had to be taken to a local hospital, started trying to see if they could get that person in a facility. It took about 8 or 9 hours from the time we went in. At a cost about $3,300 for the time. And of course, they called on the sheriff's office, which I didn't go myself, but one of my people went and took the person to a facility. They stayed 5 days, which is pretty standard, I think. And of course, then the family was called upon to go pick them up. The happened to be in Macon, Georgia. That happened in my family. Probably I was a little bit more knowledgeable and a little bit better prepared to do that than a lot of people are. I'm speaking to the people here that have the power to do something about it. There's an awful lot of people with mental health issues, with drug problems. They don't have the money, don't have the ability, and yet these are the people that are cast out. I remember when I came to Thomas County in 1963, we had a county jail that was built in 1950, and they had on it that it in the newspaper, and I happen to have the newspaper from 50. And it said, the jail is going to last us to the 21st century. Well, guess what? People didn't realize the drugs was coming to town, which they did during that period of time. And the federal government also come to town during that time. And they said our jail wasn't big enough, so they cut the beds down. So we had a lot more prisoners and a lot less beds. In those days, you had a budget, and I'm only telling you this to kind of show you the difference in what the parallel, maybe I should say, with what's going on today with mental health. We had a budget to prepare, and because, you know, county commissioners always feel that they need to cut the budget a little bit, and I recognize that, and I don't find fault with it. But the sheriff at that time had a budget of $750 for the jail for the year, other than the food. And, of course, they cut that to $640. And I've got that budget, so I can show that to you. I'm not talking about stuff.
Carlton, may I ask you a question?
Yes.
The trips to Macon and Savannah and Columbus, are those because of the fact that the mobile crisis units are full, or they don't provide enough service, or is it just because those are the closest psychiatric hospitals and these people needed to be in a psychiatric hospital?
I think it's some of both. Sometimes we are able to take them to the crisis center.
So if you could fix it, what would you do, other than not make your deputies have to drive them over there?
Well, if I could fix it, I think the answer is that we need more facilities closer. We're down in southwest Georgia. Unfortunately, a lot of people that live north of the Mason-Dixon line, and I call it the Mason-Dixon line, and in this instance, Macon, they don't think much of us folks from southwest Georgia. And unfortunately, we don't have enough of you people to have enough clout to get things done. And that's just telling it like it is. But to answer your question, I think that we're going to have to. One of the things that we're talking about today is this new opiate that's going on in the country. And some of you may have seen this morning on the news, we had a sheriff from Butler County, and I don't know where Butler County is, it's somewhere out west, I think, because he was wearing a big hat and looked like he had on some Western regalia. But he was talking about how bad that the opiate problem is. And folks, this is some bad stuff. And it hadn't really maybe gotten here as much as it has in some parts of the country. But don't think it's not coming. It's coming. And we're going to have people, and again, it's going to be affecting some people that live on the gated side of the community. It's not just going to happen to the poor folks. And so I think it's time for our legislature and our leaders here to take a look and say, at least put some facilities in our part of the state, or have a catchment area here where we could maybe keep some people for a day or two till we could get more than one person at a time being taken and come back and taken and come back. And I don't know the answers to all of this. I hope people that's a lot smarter than me know how to handle this, but I do know the problem. I don't know the answer to everything, but I know that this is a big, big problem that we have. And it's time for our people that's
Well,
in leadership positions.
I don't disagree with you, because I can imagine that somebody who is in crisis bad enough that they need to be hospitalized, that the last place they need to spend is 4 or 5 hours in the back seat of a sheriff's car.
You're absolutely right. You're absolutely right. And, you know, as long as it's that guy we don't know, it's not so bad. But when it becomes somebody we do know, that's when it's bad.
Mr. Chairman?
I could go on all day, and excuse me, ma'am.
Okay, Mr. Chairman, if I can answer, I think when this was all being discussed about the crisis intervention centers, the reason that they use the police and the sheriffs is because you've got a patient sick enough, a psychiatric patient sick enough to be transported to a hospital, and there are no state vans for the crisis intervention centers. They would have to be transferred by private car and by many of the people that are doing the interventions with them, and deciding by people, women and people who are not qualified, if they try to get out of the car and all the other problems. And I think was why the sheriffs are so involved. And it is a real problem. Sheriff Norris is a good lobbyist for you, because we hear it all the time, sir.
Yes, ma'am, I recognize that, but apparently nobody's listening to Terry. And I know you say you're maybe just howling in the wind, and I said to myself today when I walked in and saw the group, I said, I need to speak to the legislatures. Don't take this bad, folks. I mean, I'm one of you. But the rest of us can stand out there on the steps and howl and probably be making about as much good sense as sometimes we make about getting anything done. We talk about it, but we never get anything done. This is a crisis. This is an issue that needs addressing. I think it's something that is paramount to our county and this part of the state to at least have somebody. Now, again, I recognize we need law enforcement to go. A lot of these people are not just the average sick person. They're combative. They're tough to handle. I know I got a call from Tim Beard the other day, and he, and I kind of give him an earful, and if y'all see him, apologize for it. But
You can apologize yourself, he's here.
I told him, he called to tell me that they was going to have some training for our officers so we can know how to handle them. I said, Tim, we don't need training, we need some help. We're getting some place to put them, not some information on how to better handle them. Again, thank y'all for listening to me. I know I'm gonna let the chief talk about opiates. He's an expert on that better than I am. So I'll let him talk about that part of the program. But I just wanted to say to y'all that I know it's not an easy answer. I knew it wasn't when they said we had to close the hospital. I never complained about that because I knew that was a mandate. But I do know also that the people in this part of the state need someplace closer than 150 miles. Not only is it rough on us, but it's rough on the families that had to go get those people. Some of them, like I say, have no transportation. There's a lot of people out there that's basically street people, and they have this problem. And a lot of these people, once they get this problem, they become street people. They maybe not start off that way, but that's where they come to. If we got any questions, I'll be glad to answer them. Hope nobody wants to answer me one.
Thank you, Sheriff.
Well, thank you very much.
Well, when I got contacted by Mr. Bearden about talking about opioids, I was a little unaware that we had a problem around here, so I immediately started reaching out to my narcotics unit and my EMS director, and we're lucky in Thomasville we don't have that problem, as the sheriff said.
but it's a possibility, you know, like anything, it'll get here. It's just a matter of time. So we're fortunate right now. But, you know, today when we're talking about people that are in crisis, I want to talk about training for law enforcement. Because I can't tell you how important it is that the state of Georgia sponsors crisis intervention training. It's through the organization of NAMI. And this training is so beneficial to law enforcement officers that when I was at the Chiefs Conference last year, the recommended percentage of an agency should be trained in CIT is 30%. So I immediately said, how many of my officers are trained in CIT? And it was roughly right about 30, 35%, but I wanted to do more. It was my goal to get this department, my department, up to 100%, and right now I'm at 70%. But let me explain something how important CIT training is. Ever since Southwestern closed, I never knew how many times we interact with somebody in crisis. So every time we respond to a call that somebody is in crisis, we document it. And we're averaging about 170 calls a year. That's about one every other day. Now, when you deal with somebody in crisis, it's very important, number one, is to know they're in crisis and know how to deal with them. And CIT helps these officers, because what it does, it de-escalates the situation. If you look around this country, people that are in crisis are sometimes getting killed because law enforcement doesn't know how to respond to it. And I can't tell you how important it is for law enforcement, but not only law enforcement, for any medical personnel, any public safety, people in the emergency room, how to deal with somebody in crisis is critical. I have officers that are done with CIT training, and it's a 40-hour course now, it's a week long. And they say, Chief, it's the best training I've ever been to. And I'm talking, these are veterans that have been in policing for 20-something years. So when you take that concept of de-escalation and recognize when somebody's in crisis, it doesn't just help with that situation, it helps with the whole entire gamut of police use of force, and that's a hot button topic in our country right now. It's all about de-escalation and understanding what that person is going through, and the goal is to get them help. Now, the crisis center, they're great. They take them when they're available to take them. Archibald, you're a blessing, because it ties up resources for law enforcement. We don't just send one person to somebody in crisis. We send 2, 3, 4 if we have to, because it's all about mitigating that situation and make sure nobody gets hurt and we get these people the help that they need. That's what it's all about. It's about getting them help. I know Archibald, we have a security officer there at night, and we're able to assist with that situation. You know, the sheriff has the burden of transporting them after we do what we have to do. And it's a challenge, you know. The mobile crisis team, they have an hour to respond. Ladies and gentlemen, I don't have an hour to wait. Okay, and that's the truth. There's nothing against them. When I'm dealing with 4 police officers on the street and a supervisor, I need to get them help now. I don't have time to sit there and wait. So that's a challenge for us when we deal with the mobile crisis team. But who's ever in charge of funding CIT, don't take it away. It's critical. You can't stop it. And it should be mandatory that every law enforcement officer get that training. And if you have any questions, feel free to answer them.
What does CIT stand for?
Crisis Intervention Training.
And it's a week-long training?
40 hours, yes, through NAMI, N-A-M-I.
And the cost is
It's free,
free?
except for the officer's salary that you pay them. I mean, if that's what you do, it's free.
It's given for site?
It's given locally. I have 3 officers that are trained, the trainers, they can train on it, and NAMI comes down and they coordinate it. And we open it up. We've had one already so far this year, we have another one coming, and it's all done in our region. I mean, a lot of our law enforcement leaders are recognizing it, and they're just putting on training left and right. It's critical.
I've got the schedule. I know we've got one
Moultrie?
Couple of weeks in
Yeah.
Moultrie.
I got two.
If it's scheduled statewide, I'll be happy to send it.
And it ain't just for law enforcement, ladies and gentlemen. We have civilians that work for the city of Thomasville that could deal with customers that could be in crisis, and understanding, recognizing it, number one, and then able to communicate with them. That's the key. Any other questions? I appreciate your time, and thank you.
Thank you, gentlemen. I think some of our presenters from earlier today may still be here, and I don't know if any of the council members may have some questions that they've thought of since their presentations. But if any of you that are still here are still here, if you would kind of come down to the front. Miss Robin, if she's still here, I don't know if she may have had to get back. We like the accent. Any of our others that are, you may be the only one that's left. Well, since we didn't have time for questions a while ago, maybe we got time for some questions now.
I have a question. The clinic that you have at the hospital, so that it takes the pressure off of the emergency room, is it open 24/7?
No, it is not. It's open from 7 o'clock in the morning till 7 p.m. at night. We are considering opening an alternate program to be open for half a day on Saturday, but no, it's not open. It's not an urgent care center or anything like that. It's just a primary care clinic. And I do not staff it. That would become really kind of negative return, to be truthful. To pay a mid-level or physician, these people will earn a lot, you know. I mean, there's a reason why I can recruit physicians. I pay them. I pay them and I pay mid-level. Sure. Would you like me to repeat all of that? Okay. Okay, so the question was, is the rural health clinic open 24 hours a day? No, it is not. It's open about 12 hours a day, 7 a.m. to 7 p.m. We are considering opening an alternate site for 4 hours a day on Saturday, but I don't open it, to open it 24 hours a day would become negative return for us. We pay our physicians and our mid-levels a very, very competitive wage. And so to have them sit there and kind of do twiddling of the thumbs and waiting would just not be productive. You know, we did the 7 p.m. because I'll tell you, because we thought that we would be able to get patients to migrate away from the ER over there if we extended hours. But truthfully, that's not been terribly helpful. Yes, sir.
Yes, ma'am. I wanted to ask you, you talked about the mid-level providers,
Yes.
I think, the physician's assistants and the
Yes.
advanced nurse practitioner. I'm just wondering, and I'm very pro those people because I know they have a lot of abilities, a lot of training.
Uh-huh.
Is the level that you use them for, is that standard? Are you using them more than other
Yes.
rural hospitals, you think?
Oh, absolutely. I can tell you we are. And even more than tertiary care hospitals. We use them within the limits of their license, obviously. But yeah, we use them a lot more than anybody that I know.
Well, I'm just curious, if I may, and here again, I mean, I'm very pro. I had a nurse practitioner about 15 years ago. I mean, she basically was the one who was able to eventually diagnose that I had, by sending me to the specialist, that I had a cancer at that time.
Mm-hmm.
And so I just think the world of them. When you had mentioned that they pretty much manned the ER during the evening hours and I think on the weekends. Was that correct?
They man
let
the
the doc-
emergency room 24/7.
Okay.
They're back there 24/7. What they do after hours and during the weekend is they cover the floor. They're in the nursing home and they're in our hospital for two reasons. One, to avoid unnecessary transfers from our long-term care facility into our ER and avoid unnecessary admissions as well and help reduce the cost to the government. And then also, the other feature of it is it gives our physicians that lifestyle that they're looking for. They're not getting, I just about have 200 long-term care beds with 60 ventilator patients in them and another 30 trach patients. My physicians would never get any rest if they got phone calls from that constantly. So the mid-levels are kind of that buffer for them.
Thank you.
Yes, sir. Yes, sir. Yeah.
On that same note, dealing with the mid-levels, and I'm happy that y'all are using them more, because that was one of the recommendations that came out of the whole Rural Hospital Stabilization Committee, that we haven't done a lot on our end to really promote that. This year, we got into a battle over, and the Chairlady Cooper, who's very passionate about this whole opioid addiction issue, and she knows what I'm about to ask.
She should
But-
be.
So we get hit up, those of us from rural South Georgia, about, since the change was made, so the mid-level providers can't prescribe the hydrocodone. And so, like, if you got somebody, and we've tried to explain that a lot of our ERs are staffed by mid-level providers. So if you got kidney stone or a patient with a broke bone or something, they come in there, whether it's weekend or week or whatever. How do you handle that situation? If it's at night, you're not going to get a doctor to come up there and write that prescription. So what we were trying, we looked at giving them a 5-day or a 3-day limit or something to help. Well, I just would love to hear your opinion. Is that a hardship? Are you having issues with that?
That is a barrier. There's no doubt about it. But to allow them to, they'll call a physician, but to allow the physicians to, so, there's a workaround, but I'm not terribly comfortable with it, to be real honest with you.
It's a tough issue because we're dealing with such a crisis with the whole opioid issue. But then there's the hardship issue. We're trying to figure out direction, looking for direction on what we can do.
But there is pain medication that's Schedule III, which they can order.
That's right.
And they can, double up within the dose level where you might give one hydrocodone, you can give 2 tramadols. And that's what people don't want to talk about. So it's not like the patient has to go home with nothing. It's just and those are not abused like the Schedule IIs.
Right.
So.
Well, I'm sure you were. Yes, sir.
Yes, okay.
But part of,
That's what we hear all the time about the guys. You should go through, childbirth, and they don't give them opiates.
That's telling me the kidney stone is worse.
but I will also tell you, part of us, having in place 24/7 pharmacists, part of it was to deal with this.
But the doctor has to.
The doctor still has to be the one to prescribe it, absolutely. Yes, sir.
First, thank you for your willingness to share with us your success story in Miller County. My question, the 3 counties you said you have is Calhoun, Baker, and Miller.
Yes,
is your
sir.
service area? What's the total population of those 3 combined?
It's about 12,000 combined.
12,000 total.
Yeah. Calhoun, Baker, yeah. 13,000 patients. It's still small. But a large geographic area.
Yes.
And Calhoun County, Calhoun County basically doesn't even have an EMS service. Neither does Baker.
I have a question. In the metro areas, some of the hospitals have been resistant to screening in the emergency room area. Because what if they screen somebody out to one of the clinics and that person really was an emergency room patient?
It happens
and
in the
there's a
rural
problem?
areas too.
Okay, so you're just stepping out on faith and a chance. And
It is, really. I'm going to tell you, a lot of hospitals years ago went to a medical screen-out program. And in reality, that's all because they're dealing with EMTALA. That's all that we're obligated truly to do. But the reality is that when you go through a medical screening program with these patients, you have already into it thousands of dollars oftentimes. Someone comes into your emergency room with a headache, I'm going to guarantee you that they're going to, 80% of them's going to get a CAT scan of the head. And by that point in time, the game's over. So I chose to go a totally different direction because I'm already spending the money. What I need to do and what I suggest most, let me tell you, the filter's beginning to come off of my mouth now. Okay, so that's what we're supposed to be doing. We are obligated to keep them. Help keep our people, our populations healthy. That's my job as a CEO. I'm not willing to do that. I've got no darn business being the CEO of a hospital. So I'm obligated to our medical organization to keep you healthy and keep you out of our emergency room. If I can do that, I don't need to screen out the program. And that's the direction that we've taken for all of these years. Now,
But you're just, I mean, tele has been taken too literally by hospitals all over, I think because of malpractice.
it's a huge issue, and Pella cannot, Pella cannot be minimized, the impact that it has on healthcare providers. I personally think that, I've got some more personal opinions, I don't think I ought to be sharing them with you. But the truth is, what I think that is, you cannot have your cake and eat it too any longer in this country. And at some point, we've got to address all of that. If we're going to unroll healthcare, we need to look at the entire system. And some of the systems that are causing these problems of enormous expense and abuse are things of that nature. You can have one bad actor, and it causes the entire country to ripple. And sometimes we overreach. And don't we all have to change? Are you the same man that you were 10 years ago? No. So we need to be looking at But healthcare, everything that has to evolve is what I'm saying. Okay. Now, how'd you know I was looking at you? English. See, I was actually looking at the man in the pink shirt, because I think it's very nice.
But be clear.
Yes, ma'am.
To be clear, one of the cost-saving things you're doing is you are screening and sending people to the clinic.
No, ma'am.
No, okay.
No, ma'am.
No.
We treat them, and then we deal with them.
Okay, so they come to the emergency room, you're treating them there because, okay, I
been educated right in there and saying,
so the next time.
Yeah. I'm trying to learn behavior, not correct existing. What's happening today? Yeah.
When you came to the hospital, what were the number of ER visits in that year? What are your ER visit numbers today?
Okay, so it is still roughly the same. It's about 15 visits per day. It has been the same throughout these 8 years. The difference is that the visits now have a level of acuity that warrants, not all of them. We're not done. We have years to go. I mean, this isn't going to happen overnight. But what we're seeing now are more realistic ER visits. And we are keeping patients out of that emergency room. The numbers in and of themselves just obviously show that. But our EMS would tell you that for the patients that they pull on to our ER, if they bring 6 patients in a week into our emergency room, probably 2 of them are legitimate. So there's a lot of waste that is coming through EMS services. And there's another whole conversation that can be had with EMS at the table about what's going on, because that's another terrible access point and another terrible way that hospitals are being abused.
Well, that's kind of leading to what my next question was going to be. Of your 15 a day, how many are truly emergent? Or in a week's time, when you do 15 times 7 days, is it just 2 or 3 folks that are true emergent? We through the last couple of years on working on rural hospital stuff and everything, we found that we may have some extremely high visitation rates, but those that are, the admissions coming from that is another number, and then the truly emergent is a much smaller number to the point of being single digits sometimes in the multi-thousands of visits.
Well, you can, for us, I would say probably 2, and we admit an awful lot of our patients, which is very unusual. Let me just tell you, my hospital's full. I don't have a bed. I don't have a bed available. Most rural hospitals are struggling with, how do I get people in here? People call me, I got called a couple of days ago, I think it was from that man way up in the back, I forget your name, Tim somebody, or Tom somebody. And he's talking to me about about helping me fill my beds in my hospital. I was just kind of troubled, and I said, buddy, my problem is I don't have enough beds. That's an unusual problem to have, because we've created an infrastructure where we're able to care for them. So, we still transfer probably, 2 patients a day, but they're those tremendous cardiac patients and that nature.
Well, based on what you talked about here, y'all have been pretty successful, probably more so than a lot of other hospitals we've seen or I've seen and talked to, on weeding out and getting the population actually coming to the ER that needs to come to the ER versus the ones that, when we ride interstates up through Atlanta and see billboards talking about wait times at the ER, sending the absolute 180-degree opposite message of what we need to be sending to individuals riding through that community. Tell 15-minute wait time at blank hospital. That's the wrong use of the ER, and I can't understand the method to their madness in those situations.
So when we're part of that demonstration project that was mentioned a little while ago, and part of that project is we are adding, we've got four rooms, if you can call them that, 4 bays in our emergency room. We're adding on 2 more. Because the acuity level of our patients is such that now that they're not, we still get some of those headaches, don't get me wrong, please, but our acuity level is that strong now that we've outgrown those 4 beds. And we also identified mental health doesn't need to be in there, and we also don't need infectious disease in there, so. I hope that answers.
I have another question.
Yes, ma'am, I think you just need to come visit.
Yeah, and if I ever decide to go back to nursing, I think I want to come work with you. So,
Be careful what you ask for.
Okay. Because I'm pretty passionate about patient care, too.
Good.
Back to the nurse practitioners and the physician's assistants, and I have great respect for their abilities. But in the emergency room, they're not surgeons, especially nurse practitioners. The physician's assistants are more trained in the surgical area than even the nurse practitioners. But, so how do you handle, and the liability, you get a really bad car wreck and somebody's bleeding out.
Sure.
Okay. They're not really handled from, bad abdominal, so forth. You have the physician on call, and you hope, like I used to be when I first got out of school.
Okay, I'm going to tell you, what is your name?
Cooper, Sharon.
Sharon. Where do you live? Anywhere close by?
Oh, no, I live in East Cobb.
Okay, so please, come visit. I really want you to do that. Come and meet. The proudest thing that I am is about the staff that we have developed. I have not done any of this. I am just the CEO. I'm not a lab tech, I'm not a nurse. You need to come and meet my staff. Now, I can tell you that we have had, we're a farming community. We have horrible injuries that occur on tractors and with bulls and all other kinds of things. And we have flooded. I recall a year ago on 45, probably the people from Decatur County might recall it. We had a horrible, it was, oh my God, a family, a husband and wife and two babies. They're on 45, the road was flooded, he didn't realize it, and he, hydroplaned off 45, and his car flipped upside down into a flooded pasture. I remember that clearly. The husband survived. One child was, they drowned, buckled into their vehicle. That's not an unusual kind, that's a bizarre story, but that kind of accident is something that we deal with, that our staff is very, very capable of dealing with. Now, I would never take a nurse practitioner or a PA that's just come out of school and put them in our program. I mean, they have no less than 7 years' experience. And they generally come from, Phoebe is my best friend, because I steal all their best employees. I don't take too much from our department. It's okay. We take people with incredible experience.
They're not all, that's the thing about it, they're not all the same, and the training level is different. And, I know that the medical college has been contemplating like an advanced program to help with the rural areas so that, if you're a PA or a nurse practitioner and you want to go work in a rural emergency room, they have been talking about an advanced course that they could take to up the skills and so forth.
Well, and actually, they're talking to us.
Okay.
As a training site for medical students, residents, and mid-levels, because we have an array of hands-on that one can get.
Robin, we're going to wrap up this, but I do want to ask you real quickly, y'all are one of our pilot hospitals for the hospital stabilization community work. Can you tell everybody real quick what y'all are doing, the grant that you're getting through that program, and how it's affecting what you're doing?
Absolutely. So a big piece of it is identifying our strengths and weaknesses, obviously. So we are, part of our success was obviously in care management, transitional care for our patients, some of the questions that Ms. Sharon was just asking me about. So part of the grant has provided us with funds to add additional care managers to manage this chronic care disease and kind of abusers of the emergency room. And again, because we have had success with it, it's now adding to that, demonstrating for the rest of the state how useful and some hard numbers that can help. The other Achilles heel for us is our 4 beds in our emergency room, and that our acuity level is now so high and we're so limited. Think about our ventilator program and now our ventilator dialysis program. These patients are in tertiary care facilities, generally, for 11 months, 11 to 13 months, somewhere around there. They are in a unit for a long time. By the time they come to us, they have bacteria that's colonized, very, very multi-drug resistant bacteria. These are individuals who simply do not need to be in an emergency room next to a child or an elderly patient, an AIDS patient, whatever the heck it is. So and then our mental health population. We have, Kate has left the building, but we have put so much resources into mental health. Her problem now is where I was several years ago, which is now she's now versed at singing, and she doesn't have a workforce to handle the identified patients. So another piece of it is creating an I shouldn't call it an isolation room, but it is a room that's specially equipped to handle mental health individuals like the sheriffs we're talking about. It's a different category of patients that doesn't need to be in with your mother or your father. So the grant is providing us with funds for that. And then also with our outpatient or the Touchstone project that we talked about with Kay, which is the inpatient rehab program, that 28-bed unit. It's provided funding for that as well. So it's about mental health on an outpatient basis. We've got her now, we're closing on another property for her next week. We're bringing her right onto our campus next to our primary care doctors so that we can identify. It's about relationships. You can't tell somebody to do something and expect it to happen. Archibald taught me that. Expect what you inspect. And it is about relationships. So bringing them on to the program, mental health, all of those things are critical for us. Now, the grant was a $900,000 grant. We added about another $500,000 to it ourselves. Actually, $600,000 to it, including the 100 we bellied up, because we're that vested.
Okay. Thank you.
You're welcome.
Thank you for what you've done there. You and your team are saving lives and making a difference in your part of the state.
Well,
Certainly are.
think about, the economics of it, aside from the people. If you were to look at Miller County, I mean, my God, when I went there, the next year, what happened? The Great Recession. Oh, my God. Okay. And then you look at Miller County today, it's like a different town. Thank you all.
Thank you. Okay, to the committee or council members, there will be a bus at the hotel this evening at 6:30 to pick us up to haul us all to dinner. Remember, tomorrow's meeting will be in Bainbridge, so do not leave anything here in the room that is valuable to you. And take it with you for tomorrow, and we are adjourned for the day. Thank you, everybody.